3, 2, 1. We are live.
Thank you so much. Thanks, OrthoTV. Good morning, friends. This is a great pleasure. We are having a MOA masterclass on SCAPHOID, and we are fortunate that we have a galaxy of faculties with us, so that all doubts about the SCAPHOID non-union can be cleared. So I hand over to Dr. Wasudeo Gadegone sir, our president, to say a few words about this masterclass. Welcome, Gadegone sir. Under your leadership, we are having a great academic schedules, master class on from the veteran surgeons. So welcome, Gadegone sir, for this event.
Good morning to all distinguished faculties over here. Dr. Pankaj Jindal, Dr. Abhijeet Wahegaonkar, Dr. Hemant Patankar, Dr. Parag Lad, Dr. Samrat Taori, and convener of this seminar today is R M Chandak and moderator Sangeet Gawhale, and all EC members, members of Maharashtra Orthopaedic Association and viewers of OrthoTV. We have planned this is a very interesting topic, a single topic, fracture of the scaphoid. Now Dr. Samrat Taori will tell why only the scaphoid is chosen for this webinar. Over to Samrat Taori, and then Dr. Abhijeet Wahegaonkar will introduce the faculty in details. Thank you, sir.
Respected seniors, good morning. Good morning to all friends. Thank you for joining. Scaphoid fracture is important in the sense that it should not be missed. Second, it should be very well stabilized. And there are many smaller nitty-gritties about fixation, its immobilization, its rehabilitation, which we need to learn from experience of our seniors. We have Dr. Jindal, Dr. Wahegaonkar, Dr. Patankar sir to guide us. And I understand that more and more people are now operating scaphoid, and more people are now seeing more of non-union scaphoid, which we are operating. So we need to learn more about it. And as our theme goes, we need to sharpen our skill so that we get a very good outcome. And that's why we have this particular topic today. Over to Wahegaonkar sir, please.
Thank you very much, Samrat, for the invitation to be a part of this wonderful webinar along with our senior colleagues and teachers. I would like to really acknowledge and appreciate Dr. Gadegone sir's vision for the MOA Veteran Surgeons Forum, wherein we have fantastic programs scheduled and lined up, which are an outreach kind of a program to continue education. I have the distinct privilege and honor of introducing our faculty and sharing the stage with them. Dr. Hemant Patankar is a senior hand surgeon who requires no introduction. He is based out of Mumbai and is very well renowned for his commitment to academics while being very busy in clinical practice. He brings with him a very vast acumen with very practical tips and tricks and out-of-the-box thinking for the management of common as well as difficult hand problems. And I would really like to thank Dr. Hemant Patankar to be here with us today to share his knowledge and acumen on scaphoid fractures. Our senior and second speaker, Dr. Pankaj Jindal, really needs no introduction again. He's been at the left, right, and center of the hand surgery education forum of our country, in fact. And in fact, he's been my hero and my stimulus and my impetus for taking up hand surgery, for which I will always be grateful to him. Dr. Jindal is based out of Pune, but he is not only known nationally, but internationally. He's been a pioneer of sorts in hand surgery in Pune. Again, a very, very astute microsurgeon, very committed to academics and clinical practice. And he again brings with him a very, very vast and a very profound experience of hand surgery. Thank you, Jindal sir, to be with us today. Our third speaker is Dr. Parag Lad. Unfortunately, he is not able to join us due to personal reasons. Parag is based out of New Mumbai, a very dear friend, and again, a very committed academician and a clinician. And we will miss him in person, but we have his recorded talk. Our other speaker is Dr. Jain, who is a radiologist who is based out of Nagpur, and he will be talking to us about the imaging details about scaphoid fractures. And this webinar is ably moderated by Dr. Chandak sir, who is again one of the most renowned academicians and orthopedic surgeons based out of Nagpur. I'm very, very fortunate to be a part of this webinar. Thank you again, once again, Samrat, and I would ask Dr. Gadegone sir to please continue with the further proceedings. Thank you.
Dr. Samrat Taori is one of the upcoming orthopedic hand surgeons from the Vidarbha region, and he is doing entirely, only exclusively practice of hand surgery. I am proud of him. He is a young person and he is always ready to deliver something academic in a Vidarbha region. So I welcome you all and then start Chandak sir a further proceedings.
Samrat sir is going to introduce Dr. Abhijeet Wahegaonkar sir.
Yes.
Abhijeet sir is a senior hand surgeon. He's practicing in Pune since about 15 years. And we call him Guru because he's called Waheguru among all our young hand surgeons. And he has got an extreme scientific acumen and reasoning. When we discuss with him, he is always ready to share those experience so we understand how deep his knowledge is. And he accepted the invitation very in a second, and I'm very thankful to him for that. And we look forward for a very interesting discussion on two cases which he is going to present. Welcome, Wahegaonkar sir. Chandak sir will be starting with clinical presentation by Wahegaonkar sir.
Yeah, absolutely. So we have a wonderful lectures ahead of us, and we'll all really enjoy these talks. So may I invite Dr. Wahegaonkar for his case scenario, acute fracture treated with internal fixation. And that would be really interesting because that is what we look forward when we have a scaphoid in theater or in our chamber and we want to go ahead for management of such a case. Welcome, sir.
Thank you. Thank you very much. Thank you, Samrat, for the kind introduction. But I must confess that I'm just a reflection of my teachers. And once again, this is a wonderful seminar, and I would like to begin with the first assigned talk, which is on the acute fracture clinical scenario of the scaphoid. And I have no conflict of interest regarding this presentation. So the objectives of this talk will be to understand the basic anatomy and the mechanism of scaphoid fractures, as well as to understand a little bit about the classification and treatment recommendation. And of course, through the webinar, we'll be understanding more and more of this aspect. So here is a case example. This is a 17-year-old student and a very avid football player who wants to make his career in football as well. And he sustained an injury while playing the game and presented to a clinic with the complaints of inability to play. He's a goalkeeper and pain in the wrist joint, so he could not commit to the game. He's right hand dominant and then has pain with activity and no pain at rest. He was initially splintered but allowed to play because of the games of the tournament. However, 2 weeks later, he found that the pain continued with the movement of the wrist joint being painful and restricted. There was reduced grip strength. There was tenderness in the snuff box on clinical examination, and he got some x-rays done that showed a scaphoid fracture. Sometimes we also find that the scaphoid fracture may be very subtle and may not be visible on x-rays in the initial setup, and then we are kind of wondering if there is a scaphoid fracture. We get repeat x-rays at around 10 days to 2 weeks, and that kind of gives you a clue. So here is the initial x-ray. Is there any scaphoid fracture visible on this? To most of the people, we may not be able to pick up the fracture, but if you look very carefully,
yes,
there is something going on in this region,
yes,
which might help you or which might raise the suspicion of a scaphoid fracture. It is also advisable to get some stress views to put into evidence the presence of a fracture, but very many times this may not be very evident of a scaphoid fracture on the initial X-rays, in which case the question is what should be done to diagnose if the pain continues and if there is restriction of movements with grip strength and tenderness in the scaphoid, in the anatomical snuff box, as well as on the scaphoid. So we have the options of performing either a CT scan, an MRI, or a bone scan. Of course, the bone scan is redundant these days, and more often than not, we resort to a CT scan. So in this patient's case, we opted to go ahead with a CT scan, which revealed the fracture. At the same time, there was some diastasis of the scapholunate. We were not sure because it's very difficult to comment on a CT scan whether the scapholunate is injured or not. But a lot of times we see in children, this may be the case without any injury to the scapholunate ligament. We also find that there is some DC deformity, and the scaphoid was fractured in the proximal pole. So again, now once you have into evidence of the fracture of the scaphoid, we beg the question as to what the treatment options might be. And there is a litany of treatment options that is available for patients who present in this manner. And this could range from a scaphoid cast to a percutaneous fixation, open reduction internal fixation with K wires or with a compression screw. And this may or may not be complemented with bone grafting. Usually cancel is bone graft because there is no resorption of bone in the acute setting usually. And to just add to the palate, we also now have what is called as arthroscopy assisted reduction and internal fixation of the scaphoid fracture. So in this case, we decided to go ahead with open reduction internal fixation with a dorsal approach. And these are the steps of the surgery. I won't belabor too much on this because this will be covered in subsequent talks. And this is just to show the clinical scenario. And this is the fixation image on Shyam at the time of surgery. Very quickly, I would like to discuss the intricacies or the details that are involved with decision making in these fractures. And we need to take into account the anatomy as well as the vascular supply of the scaphoid, which is very tenacious, as we all know. And that is the reason why these fractures are very prone to going on into non-union. As you can see that there are two predominant blood supply to the scaphoid, which was studied by Richard Gelberman in these anatomical studies. And we now know that there's a superficial palmar branch of the radial artery and a dorsal carpal branch of the radial artery that are the predominant supply to the scaphoid. These fractures are usually sustained as a hyperextension injury in more than 95% of the cases. And there is kind of a nutcracker effect, as we call it, between the distal radius and the distal carpal row, wherein the scaphoid gets squished and will have bending forces and will fracture. Anatomical location-wise, the commonest fractures are in the waist of the scaphoid, followed by the proximal pole and then by the distal pole. There are several classifications that have been described in literature. The Mayo classification is dependent on the localization of the fracture. The Rusi classification, pretty much like fractures of the neck of the femur, will take into account the plane of the fracture, whereas the Herbert and Fisher classification take into account the stability of the fracture. So this is a schematic diagram of the Mayo classification, which has got 5 subtypes, as is highlighted on this slide. You have the Rusi classification based on the obliquity of the fracture line, and this is how we classify them. And then, of course, it doesn't take much imagination to understand that the increasing obliquity is associated with worse prognosis because there are shear forces and a risk of displacement of these fractures. The Herbert and Fisher classification take into consideration the stability and the history, and you have 4 subtypes as is highlighted on this slide. And then you also have the Cooney classification, which is a further modified classification by identifying unstable fractures. And it's interesting to know that he advocated fixation for all unstable injuries at the get-go. So what is the rationale for operative treatment? it is based on these complications that we may encounter. The non-union rate can be as high as 40% with acute scaphoid fractures, with malunion also being as high as 30%, and then delayed healing taking a lot of time. And these are the recommendations why people may consider open reduction or fixation of the scaphoid fracture, surgical treatment of the scaphoid. So the scaphoid is a very peculiar bone, which is intra-articular with a large articular surface, and no external collar or fracture callus is usually formed to stabilize the bone. And therefore, the purpose of implants is to stabilize the fracture site and prevent shearing forces until the union is occurring. And this may be accomplished either by K-wires, by screws, and so on and so forth. So the role there is also a role of acute limited open reduction internal fixation, acute scaphoid fractures, and that is to provide compression while the fracture is healing. And the decision is based on the assumption that all scaphoid fractures are inherently unstable, and therefore the fixation should be the choice of treatment. However, there is always a role for non-operative treatment, and we'll understand that again in the subsequent talks. The diagnosis is essentially based on clinical examination coupled with radiological examination, and the overall clinical examination can have 100% sensitivity with a 75% specificity should you perform it thoroughly and objectively. So we look for tenderness in the anatomical snuff box over the dorsal aspect of the scaphoid, and we do a compression test also. The imaging studies also have been described in literature with their sensitivity and specificity, and they are listed here. I won't belabor too much on this. And we need to calculate the different angles that are present, the scaphocapitate angle, as well as the scapholunate angles that give you the bending, as well as the intrascaphoid angle. So whenever there is a bending fracture with angulation, these are best treated with open reduction internal fixation. However, those who are well versed with the percutaneous techniques also will be comfortable using them. Again, there is a litany of implants that are available, which will be discussed in greater detail. So I won't belabor too much on this. There are several of them that are available. The usual recommendation for the approach is listed here. We use a dorsal approach for proximal fractures, a palmar approach for the waist or the distal fractures. Again, the sequence of fixation is that we have to imagine the scaphoid in 3D and understand the 3D displacement, stabilize with K-wire, and then we put in a screw, either antegrade or retrograde. There are several problems that are associated with the use of these screws, and we have to be very well versed. There is a learning curve. We need to be above the learning curve. Commonest problems that we see are incorrect insertion, screws projecting into the joint and causing problems, and we need to be very careful. There are certain controversial areas that we face in clinical practice. The most common and the challenging one is, should fixation of scaphoid be routine? What is the role of percutaneous screw fixation? And should we be accepting scaphoid malunions? There are certain recommendations saying that some degree of scaphoid malunion can be acceptable as long as the clinical results are okay. Immobilization post-surgical reduction is again a very, very controversial as well as a debated area, with people recommending no immobilization, whereas there are groups that recommend immobilization, and again, the association of ligament injuries as well as the fractures that are present in athletes and sportsmen. Julio Telesnik, in way back in 1985, he said that there is so much of lack of uniformity that some more immobilization is important rather than what position the limb should be placed in. So in summary, it is, I think, a good idea to assume that all scaphoid fractures are displaced and are inherently unstable and treat them aggressively, either with immobilization or with fixation, which can be percutaneous or open. The operative approach is based on the displacement as well as the location of the fractures. The recommended strategy is percutaneous fixation for minimally displaced fractures, open reduction internal fixation for displaced fractures. If the fracture is in the proximal third, we usually use a dorsal approach, whereas for the distal third in the waist, you may want to use a volar approach. And the fixation could be with K wires or with screws, depending upon your preference. Just to add to the flavor, arthroscopic assisted reduction and internal fixation is something that is performed by more and more people across the globe. What it does is that it allows us to verify the location of the wire, whether it is projecting into the joint or not, confirm it accordingly, and then place it correctly. So with that, I thank you for the opportunity to contribute to this webinar.
Thank
Should
you
I
very much, sir.
continue with the second talk
Yeah.
or yeah?
No, we'll have
All
some
right, sir.
we'll have a short discussion on it.
All right, sir. All right.
So Abhijeet, when you fix the fracture,
मैं बेटी को फोन करने को बोलता हूँ आपको.
after fixing the fracture, how will you judge that the fracture has united?
All right. That's a good question, sir. So the assessment of fracture union is based on sequential X-rays through the fracture time as well as clinical examination to document absence of tenderness as well as pain with wrist movement when rehabilitation is started and the immobilization period has ended. The immobilization period is usually anywhere between 4 to 6 weeks. However, we counsel the patient that your immobilization will continue till such time that the fracture has healed clinically as well as radiologically. If there is any doubt about the union on X-rays at the end of about 2 months to 3 months, the recommendation is to get a CT scan done, and we advise a CT scan to look for the presence of bridging trabeculae to confirm the union of the fracture. One of the most important things that we should take into consideration is the smoking status. I was just speaking to one of my colleagues in the UK, and they said that smokers are outright rejected from treatment because of the high rate of non-union and litigation that is involved with scaphoid fractures. So smoking is a very, very important factor to be taken into consideration when dealing with scaphoid fractures.
Coming to the implant of choice, headless compression screw or a K-wire or two parallel K-wire, what is your strategy? In which cases you would?
Right, sir. So we will be talking about implants in greater detail. Dr. Patankar will be covering,
Yeah.
Dr. Jindal will also be, but very quickly, if it's a proximal pole fracture where there's only a shell that is present, obviously we cannot use a screw in these fractures. And in these cases, you may very well get away by using K-wires, and that is the usual strategy. Again, in waist fractures, and you will see from Dr. Patankar's series that K-wires work as well as screws do, provided you follow certain basic tenets of treatment, and they are quite useful as well. The screws, although have been shown to be biomechanically stronger or better than K-wires, there is a very high rate of complications that is associated with the use of headless compression screws, especially from the point of view of placement of the screw as well as the screw size and so on and so forth. So I really think that we should be very well versed with the use of screws. My personal preference is for, of course, a headless compression screw, and we usually tend to use a fully threaded screw that is of the Acute drag or the Arthrex. No conflict of interest here, and that is what we prefer to use. And sometimes we even couple it with a derotation K wire.
Okay, thank you very much. So with this, we move up to the next lecture.
Yes, sir.
Yeah. So the next lecture again would be by Dr. Wahegaonkar, sir. The case scenario is a non-union now. So we'll be discussing about the case and a non-union. Please go ahead.
Right.
Sir.
Thank you. Thank you so much. So again, very quickly, the objectives of this talk will be to understand the mechanisms of injury, classifications related to scaphoid non-union, and to understand the management of non-union, and to understand the snack risk. I won't be going into the details of this because this will be covered in detail in subsequent talks. So non-union is generally defined as failure of healing by about 6 to 12 months from injury. And Joe Dias from the UK concluded that it is difficult to determine union, and the radiographic diagnosis unreliable in patients who have a scaphoid fracture and they are less than 3 months from injury. The natural history of scaphoid non-union has also been very widely described and has been studied in detail. And again, Gelverman's group has published this very important paper, which I urge you all to read, from JBJS in 1984, wherein they concluded that the scaphoid displacement and carpal instability correlated with the severity of the degenerative changes, and all displaced ununited scaphoid fractures should be reduced and grafted regardless of the symptoms before the degenerative changes occur. So with that brief introduction, here is a case example of a 25-year-old right-hand dominant student who injured his wrist again in a football game. He sought medical attention for pain, and then he was seen in a clinic where the x-rays were deemed to be negative and was treated symptomatically. And these were his x-rays at presentation. And I'm sure most of you would perhaps agree with the fact that there is nothing much going on that meets the eye. However, the pain continued, and he was referred to us on clinical examination. We found tenderness in the snuff box. There was no click or snap at the wrist range of movement. However, we found that the grip strength was reduced and the range of motion was also reduced. And we got a fresh set of x-rays at that time. And this is what we saw. So you can now see on the posterior anterior view that there is some kind of a resorption of bone here. And then on the oblique view, again, you see some kind of a resorption here. Lateral view, again, if you look very carefully, but you don't see a DC pattern. And there is obviously scaphoid non-union, and that is very evident out here. We also got an MRI of the wrist joint just to kind of add to the completeness of the radiological examination. We'll understand a little bit more about this in the subsequent talks. But now we have more and more consensus that the MRI is not the best way to diagnose avascular necrosis. So the standard operative approach, wherein we expose the scaphoid through the FCR subsheath, and then you put into evidence the non-union site, you cure it and clean it of the fibrous tissue. We measure the gap, correct the intra-articular angulation of the intrascaphoid angle. We correct the flexion of the distal pole. That's the gap which is present, and then which is filled with a structural bone graft obtained from the iliac crest, and you fix it with a screw, or a headless compression screw, and that is the post-op X-ray. So what are the treatment considerations when we are looking at scaphoid non-union? So broadly, they can be classified as those related to the bone, which include the location of the non-union, the classification, the duration since the injury, the gap that is present, if there is any dissociative instability of the proximal carpal row in terms of DC, the vascularity of the bone, any degenerative changes or any associated injuries such as transcaphoid perilunar dislocation, for example. The patient factors would include the age, the dominance, the demands of the patient. Smoking is a very big factor to be taken into consideration along with comorbidities. And then the surgeon factors, which include training, the choice of implant, the availability of those implants, and the choice of the bone graft. So the scaphoid, again, as you understand from the previous talk, is an awkward but important little bone. And this was the observation of Nicholas Barton, and it originates from the Greek word scaphos, which is boat, and an EDOs, like it's a boat-shaped bone. And it's a really interesting little bone which articulates with the distal radius, the lunate on the medial aspect, the capitate, the trapezoid, and the trapezium. And the scaphoid is attached via different ligaments to the proximal and the distal row. There are three main anatomical regions that we talk about: the proximal pole, the waist, and the distal pole, or the tubercle. We have discussed the blood supply, so I won't belabor too much on this. And there are a lot of people who extrapolate the similarities of scaphoid fractures from femoral neck fractures. In terms of the tenuous blood supply that we just discussed, it is an intra-articular or an intracapsular fracture. There is no true periosteum in both these anatomical locations. The fracture configurations are pretty similar in terms of obliquity, and these fractures result from high torque at the fracture site. And again, this is a schematic diagram to show how the scaphoid would fracture from a foosh or a fall on an outstretched hand, where there is an hyperextension injury, and there is an impingement of the dorsal rim of the radius on to the scaphoid, and there is a bending in the waist of the scaphoid that results in the fracture. It is predominantly seen in males in the age group of 15 to 40, but it may be seen at any point in time, usually again predominantly seen in sportsmen and active people, and results from a fall on an outstretched hand in the majority of cases. So with that understanding, what are the preventable causes of scaphoid non-union? And more often than not, and pretty much on the top of the list, is failure to recognize the fracture at the get-go. This is perhaps the single most important reason why a scaphoid fracture would progress to non-union. And of course, there would be another consideration such as inadequate initial treatment or improper assessment of bone healing. And these are pretty intuitive kind of preventable causes of scaphoid non-union that I'm sure most of you would agree with. The delayed treatment risk factors are failure to seek treatment, because a lot of times this is diagnosed and treated as a wrist sprain, and minimally displaced fractures will again be reported as negative on the X-ray. And if seen by an orthopod or a surgeon who is not aware of this diagnosis, this is perhaps one of the most important reasons why the scaphoid will progress to non-union. Physical examination of patients who present with a non-union will begin with thorough clinical history. We perform axial loading and grip strength assessment, and we find that that will be painful. There is a paper by Javad Parviz, who's actually now a hip surgeon, but he published this paper in the Journal of Hand Surgery British in 1998, where he came up with three pointers: snuffbox tenderness, tenderness of the scaphoid tubercle, and pain on axial compression. These will have 100% sensitivity for diagnosing scaphoid fractures. So one more very interesting kind of pointer is that not all non-unions are painful. And again, that is the reason why they go unnoticed and undiagnosed for a very long time. However, when you do encounter a patient, we begin with imaging, and we first get a good set of X-rays, wherein we get a PA view in the so-called neutral position, where the shoulder is in 90 degrees of abduction and the elbow in 90 degrees of flexion, a true lateral view. You get an ulnar and a radial semi-pronated and semi-supinated oblique views, and you also get some radial and ulnar deviation views to complete the radiological examination. You also would get some CT scans done, wherein you look at the intrascaphoid angle, and you look at the radial lunate angle as well as the capitolunate angles to look at the DC deformity and the dorsal tilt of the scaphoid. There is always a debate whether we should get an MRI or a CT scan. Again, we'll understand that in the subsequent talk. But as a very broad kind of a pointer, CT scan is usually recommended to assess union, whereas MRI is usually recommended to assess vascularity and soft tissue injury. The classification of scaphoid non-union has been again described by various authors. This is taken from Green's textbook, wherein There is a classification from grade 1 to grade 6, which talks about sequential bone loss and then pseudoarthrosis. There is another classification wherein you talk about fibrous non-union, cystic non-union, sclerotic, and avascular. And this comes from the French author Jean-Yves Alnot. The location of the fracture would kind of give you a clue whether this fracture is going to unite or not. The schematic diagram kind of shows the location as well as the patterns which will more often than not unite, and then there are fractures which may not unite because of the obliquity and the location of the fracture. These are again schematic kind of a representation, a tabular representation of what should be done for what type of fracture, and the recommendations are listed here. And this is out there for all of you to read. Again, this is a very brief summary of what should be done when patient presents to you at what stage of non-union. This will be discussed in further talks. The treatment options again have been described, and they vary from just kind of percutaneous stabilization for fibrous non-union, open reduction with bone grafting for established non-unions. When there is some doubt of vascularity, you may want to bring in vascularity by performing a vascularized bone graft, which could either be a pedicle or a free vascularized bone graft. And now the new trend is towards arthroscopy-assisted reduction, bone grafting, and fixation. Standard approach with bone grafting, again, I would belabor too much on this. This will be discussed. Vascularized bone grafts have also been described. The commonest and the most popular one that is used is a bone graft on the distal radius based on a pedicle on the dorsal aspect of the radius. Is called as a 1-2 ICSRA. Arthroscopy-assisted bone grafting is also something that is being performed more and more widely. The bone graft could be harvested either from the lateral aspect of the distal radius or from the ICBG or from the iliac crest. Here is a case wherein you can see an established non-union with resorption of the bone, some sclerosis of the fracture lines, and this is how we go about performing the arthroscopy-assisted bone grafting and reduction. So we harvest the bone graft using either a J needle or just get cancellous bone that is compacted. I'm using a plastic cannula out there to put in my bone graft, and we impact the bone graft using a freer elevator. And once we have completed the bone grafting, we so again, this is an arthroscopic view of the bone graft coming in and being impacted into the non-union site. And once that is done, you have adequate bone graft in the non-union site. You would then proceed with your fixation, which is again a percutaneous fixation. You get your guide wire in the correct axis in the anteroposterior as well as the lateral planes. And once you have confirmed, you would put your screw inside. So this is to show the minimally invasive portals, and that is the arthroscopic fixation. There was a question by Chandak sir earlier on whether K-wires are also the option for fixation. Of course, and in such fractures wherein there is a very proximal non-union, as there is no bone stock for screw fixation, we would like to use K-wires. The recommendation is that we advance this into the lunate as well, so as to achieve stability at the fracture site. So there are very many ways to skin a cat, and screws or K-wires serve the purpose. There are even people who just use peg bone grafts without any fixation. The fate of failed bone grafts is again something that needs to be taken into consideration. Revision surgery usually is associated with more and more complications, and Dr. Jindal will be talking about the strategy of what to do after there is a open reduction internal fixation and ensuing non-union. Snack wrist again will be covered in greater detail with the treatment options for them. I won't belabor too much on this. So in conclusion, this fracture is a very, very commonly missed problem, fracture and misdiagnosis of common injury. Natural history of untreated non-unions is degenerative wrist changes, misdiagnosis, And inadequate or improper treatment is the most important common preventable cause for scaphoid non-union. And I always say that it is better to err on the side of over-treating than otherwise. And all is not lost, even if non-union occurs. Accurate diagnosis and optimum treatment will usually help resolve this problem. So with that, I thank you for the opportunity to contribute to this webinar. Thank you so much.
Wonderful disposition of the subject, acute and non-union, Abhijeet. It's a very wonderful overview, and probably the things will be more and more clear after the subsequent speakers. But you have given a good, you have done a very, very good job of understanding the subject of scaphoid, acute fracture, as well as the non-union. Thank you very much.
Thank you so much. Samrat, you wanted to comment or give a question?
Yeah, I've got a few questions, sir.
Yeah.
To Abhijeet sir, and we may have the answer at the end also. But there are situations, and this is a practical question asked to me by our dear friend Dr. Loda from Hinganghat, that people come with a displaced fracture scaphoid and they are not ready for anything, not even free K-wire. How to go about it? Because there is one small mention in AO where they put a cast using a volar pressure for the distal pole and putting a dorsal pressure on the capitate so as to sort of reduce the fracture and then put a cast. What is your experience on this? Because there are people who are not ready for any sort of treatment, and we know that it's going to get into non-union. So that's one thing I wanted to know.
But they're ready for a plaster cast.
They are ready for the plaster cast.
Okay.
But should we think about close reduction, or we should not think, and what should be consent? And one more interesting thing is probably that's out of the
let him answer first.
Okay.
Yeah.
All right. Samrat, thank you very much for that question. So I think as doctors and physicians and surgeons, putting our patient's best interest first is our primary moral obligation. Patients do not understand what is the difference between a non-operative or an operative treatment. They're compelled more by impulse rather than scientific facts, which we are more aware of. And it is, I think, our responsibility and duty to explain to the patient in great detail, spend time with them and help them understand why we are recommending surgery. Of course, there are always outliers, and there are always people who would still refuse the treatment despite your best efforts. And in which case, it is, I think, very important to document all of these details on your note, saying that all the options and outcomes were discussed, and yet the patient refused, and therefore the decision was to go ahead with a plaster. However, at the same time, you may also have the ability to get a counseling or an opinion from a senior or a more kind of an experienced colleague. And I think that also should be done, because sometimes senior colleagues may be influential or may be helpful in helping the patient choose the right kind of treatment. So I think we should not act like we are all knowing, or we are trying to compel. Please get a second opinion. Advise the patient, look, this is what I think is in your best interest. I would like you to get a second opinion if you still have any doubts. But just like the shepherd guides his sheep, we need to guide our patient. That's what I think. We should not be, prejudiced by what a patient, it is his right to decide. And yet we should do our best to help them make the right decision. Now, obviously, when the AO technique of reduction was published, obviously we were not very well versed with the intricacies of scaphoid, displaced fracture scaphoids, or whatever happens if they are left untreated. The very fact that a scaphoid fracture is displaced means it is inherently unstable. So in spite of your best efforts to perform a close reduction, there is a very high chance that it will displace. So I think we should do our best. I don't have a good answer how, but maybe seeking the advice of a senior and a more experienced surgeon, taking time to talk to our patients, helping them understand, I think are the way to go. That's just my 2
So,
cents.
Samrat, we will proceed with the next
Yes,
lecture
sir.
and then take up questions at a later
Yes,
date.
sir.
So with those wonderful explanations, sir, so guide the patient properly and convince him to the most advantageous treatment methodology. Now, may I invite Dr. Patankar, sir, to go ahead with his lecture on planning of surgery, evaluation, approach, and the implant and the bone graft. These are the main questions when we take up a patient for surgery for a scaphoid. So that would be wonderful to listen to. Welcome, Patankar, sir. Can you please share your screen, sir?
Yeah.
Yeah, no problem. Go ahead, sir. It's always a pleasure to listen to Patankar, sir, for simple treatment options and simplicity of treatment protocols.
Where is the screen?
So you can, on the bottom of the thing, you will be
Yeah,
seeing
is
share
there.
screen.
Yeah.
Yeah, no problem.
Can you
Yeah,
see?
yeah. Now we can see, sir.
Oh, I thought
Yeah.
this is not the one to be shown.
No, no,
Okay,
we
fine.
are saying, yeah. Just go
Okay.
full screen. Yeah.
Yeah. Is this fine?
Perfect. Absolutely
Yeah.
perfect.
Okay. I thank Dr. Gadegone sir and Dr. Chandak and Samrat and the MOA to allow me to share my experiences on scaphoid fractures. I may, as a nostalgic thing, since I am speaking from Amravati, most of the cases of non-unions I have done at Amravati. So it's a great feeling for me to be speaking on scaphoid from Amravati. With that small introduction, I thank Abhijeet because he has simplified my job. As you all know, I don't like to speak on theory and text, and I'm very bad at explaining all the things mentioned in journals. I'd like to go right away with my clinical experiences on scaphoid fractures. So, as you all know, it's the most common carpal bone fracture, but more than that, it's the most commonly missed fracture in the hand or in the wrist. And that's the commonest cause of the fracture, the fall on the outstretched hand. The problem is that many times the surgeon takes an X-ray, but it doesn't examine the patient clinically. And tenderness in the snub box is the only sign which is available apart from the history, which should make us suspicious that this could be a fracture, irrespective of the fact whether X-ray is taken properly or not, and X-ray doesn't show the fracture. And if there is a tenderness in the snub box, it is a scaphoid until presumed otherwise or diagnosed otherwise, because there is no other external appearance on scaphoid. There is no deformity. There may or may not be swelling, but tenderness is definitely there. So the diagnosis of scaphoid fracture is most important. You have to have a very high level of suspicion, and you suspect a fracture till it is proved otherwise. Many times the fracture is not seen on the initial X-ray, or sometimes the fracture is seen. Many times the patient presents late or patient present with non-union. So these are the 4 scenarios that we see in clinical practice. Most of the times, the patients present with these 2 views. They are not enough. Even if this patient had a fracture of scaphoid, it is very difficult for us to understand. And if you don't understand, how can you convince the patient that this is a fracture of the scaphoid? So whenever there is a tenderness in the snub box or in the fall on the outstretched hand with a pain in the wrist and tenderness there, you should take 4 views. So these 4 views of the wrist, if the patient is not in pain, you should take it with ulnar deviation and wrist extension. So these 4 views are important. Mind you, don't write for a lateral view. If you don't suspect a perilunate dislocation, lateral view is not important. It does not help us to diagnose a scaphoid fracture in the lateral view. The lateral view is important or very important if there is a transscaphoid or a perilunate or lunate dislocation. It does not, still in this case, you cannot see a scaphoid fracture very clearly, but you can definitely see that there is a, I would say, dislocation between the capitate and the lunate. And you can just mark out the lines mentally in your brain. and that this is the whole thing is disturbed, and this is the normal appearance of the lateral view. So as you can see, the lateral view is very important to know a carpal instability or a perilunate or lunate dislocation, but per se it does not help us to diagnose a scaphoid fracture. As I have mentioned, the ulnar deviation view with the patient's pain is less. Please take an ulnar deviation view in AP and PA view, and you can definitely diagnose a scaphoid fracture and proceed with your treatment. The another secret or another thing which I have found in clinical practice is many of the technicians, they are still, in spite of saying ulnar deviation and all that, they don't take a proper view of the scaphoid. So you ask them to take an X-ray of the thumb with the wrist in AP lateral and oblique, and you will definitely see the whole scaphoid. Now this patient was taken, X-ray was taken for a thumb problem, but I realized that the X-ray technician has taken an excellent view. This is a dead AP view of the thumb. This is the lateral view of the thumb, and this is the oblique view of the thumb. In all the views, apart from seeing the thumb, you are seeing the trapeziometacarpal joint, and you are seeing the scaphoid perfectly in all the three views. So that made me realize that if I cannot see a scaphoid fracture properly in the standard wrist views, I asked them to take an X-ray of the thumb with the wrist, AP lateral and oblique, and then you can see the scaphoid perfectly in this. Obviously, as Abhijeet has mentioned, a CT scan is very important for doubtful cases. I don't take an MRI. MRI is confusing a picture. I cannot interpret an MRI myself, so I don't like to rely upon somebody else's reports for an MRI. If the X-ray if the initial injury X-ray does not reveal a fracture, then what next? If the X-rays are equivocal, if the history and clinical findings suggest that there is a fracture, I presume that there is a scaphoid fracture and apply a cast. Now, the scaphoid cast per se is very, very controversial. I would personally advise that whatever level of the cast or whatever extent of the cast you are comfortable in, and where you are seeing or where you have been trained or where you have got good results, that is the type of cast you should apply. I apply a below elbow cast, keeping the thumb in abduction and keeping the IP joint of the thumb free. I immobilize the MP joint of the thumb. I keep the fingers free completely from the MP joint onwards. I prescribe NSAIDs for relieving the pain. In all these cases, suspected cases, I recall the patient after 15 days. I remove the plaster and repeat the 4 scaphoid views. And if the if the X-rays reveal this thing, if the X-rays reveal fracture, I advise fixation of the fracture. Especially if you get a picture like this after 15 days, then you should advise fixation. However, if the X-rays are equivocal, but you are clinically doubtful, then you ask for a CT scan. Especially look at the sagittal view. If the fracture is seen, reapply the cast. If the fracture is seen on the CT scan, but not seen on the X-ray, reapply the cast and repeat the X-ray out of cast after 6 weeks. If the fracture is not visible at 6 weeks, no further treatment is required and the patient is to report SOS. However, if the fracture is seen on the first X-ray, especially such a clear fracture is seen on the first X-ray, do you cast it? I use this argument. This is the sentence which I liked very nicely. Scaphoid fractures are very hard to immobilize, since nearly every motion of the wrist, hand and forearm causes movement of the bone and pressure on the fracture line. So really speaking, if the fracture is seen on the X-ray, that means it was a displaced fracture at the time of injury, and it will not be amenable to a cast or a immobilization, only a plaster immobilization, and you should fix it if the fracture is seen on the first X-ray. So how do you fix a fracture? Now this K-wire versus screw is a great controversy which is going on. I think it is endless controversy. I will tell you the things which are in favor of K-wire and which are in favor of screw. So my choice for waist fractures, if the patient can afford, if it is available, I use a Synthes 2.4 millimeter headless compression screw. If the patient can afford it, if the patient cannot afford it, it does not matter. I use a percutaneous retrograde K-wire fixation using 1 to 1.5 millimeter wires. If you feel that the fracture is stable with one wire, there is no need to put a second wire. If you feel that the fracture is moving or if the gap is there, then you can press the fracture after putting a first wire and then insert a second wire later on. Now, this is an example where there was a fracture through the waist. You can see in this X-ray also the lateral view really does not show anything. These are very old cases which I am showing you. However, this fracture was treated with two 1.5 millimeter wires. You can still see that there is a small gap here. Of course, in all these cases, I used to use these K-wires quite a lot in the past because the screws were not available. Mediclaim was not very common at that time, insurance. So patients would not really afford a screw and they were not really available at that time. So you can see in spite of the gap in this X-ray, in the previous X-ray, after immobilization of the plaster, of the wrist in a plaster for a reasonable period of time, you can see that the fracture is completely united. And this is a general practitioner. He has had a very good function after that. Now in the proximal third fractures, definitely a screw is a no-no because I personally don't use or like to use an antegrade screw because I think we are invading the wrist joint. And secondly, there is too less a quantity of bone proximally for inserting the screw. I fear that even inserting a 2.4 millimeter AO screw might shatter the proximal end. So I prefer to use a percutaneous retrograde K-wire fixation using 1 or 1.5 millimeter K-wires. So this is an example of fracture of the proximal third. That is a proximal third fracture. Even in this case, the amount of bone that is available is quite a bit. So I think we are very comfortable using K-wire. This, of course, could have been treated with a screw because quite a good quantity of bone is available in the proximal end. So you can see this is the fracture which is displaced. And this was treated with two 1.5 millimeter K-wires. Again, this was immobilized for about 3 months in a plaster. And you can see that the fracture is completely healed. These K-wires were removed at 6 months. You can see in this X-ray, you have to take multiple X-rays again. A supine oblique view, as I will show you later on, is very important. It will show you, in fact, all the oblique views of the wrist are very important to see all the nooks and corners of the wrist and the scaphocapitate joint to know or confirm the union. This is the case. This is the same case of a proximal third non-union scaphoid fracture who has done very well with K-wires. This is X-ray, obviously, a picture after taken after removal of the K-wires. So the crux is that K-wire provides interfragment or prevents interfragmentary mobility, and that I think is very important to achieve union. There's really no need to achieve compression. Screws often or obviously provide compression, and that is the role of the screws to provide compression. But K-wire prevents interfragmentary mobility, and you can safely immobilize the wrist in a plaster and the fracture will unite. Because of the limits of time, I am not showing you more than one case per example. The K-wire obviously is a first step in insertion of a compression screw. So we must master the art of putting a K-wire in the scaphoid. That is the second reason for starting using the K-wires. Initially, when your practice is new, I would suggest that you should use K-wires. You can obviously start with the screw also, but mastering the art of putting a K-wire in or fixing a scaphoid with a K-wire goes a long way in, or I would say mastering the art of screw fixation using a very small diameter screw. I would not recommend the 3.5 millimeter screws because they are too big for Indian bones, according to me. So this is how we use or insert screws on K-wires. That is the K-wire which was inserted into the scaphoid, and now a headless compression screw is being inserted. So the other advantage of K-wires is 2 K-wires will cost you rupees 50 against about 9,000 rupees for the screw. K-wires again are available in every orthopedic OT. You don't require any special instruments. You hardly require a power drill. Of course, if you have a low torque or high torque, low speed drill, that goes a long way in your fixation or helpful in the fixation. But it is, I think, personally very difficult to put K-wires in the scaphoid using a large or big drills because it, I think, hampers the precision. So no special instruments are required. You require a T-handle with chuck, which is available in every OT. I have made a small T-handle and attached a small chuck to that. You require a sharp K-wire cutter and you require a Shyam. These are the only instruments that you require. A sharp cutter, a T-handle with a chuck. These are the K-wires. You require a 15 number blade to make a nick on the skin. You, with an artery forceps, you have to go between the trapezium and the scaphoid, identify the bone and start inserting the K-wire. That's how you insert the K-wires. I like to use a Shyam camera under the handboard. I use a wooden board, or you can use an acrylic sheet mounted on a steel frame. And you can direct the K-wires slightly medial to the APL tendon, or go at the level of the scaphotrapezial joint, and you insert the K-wire in this manner. And it is recommended you go to in the direction of the Lister's tubercle dorsally and angulate the K-wires in the direction of the Lister tubercle, or in Lister tubercle on the DRU joint. I like to insert the K-wires with the entry in the prone oblique position. And after reduction of the fracture will automatically reduce if you keep a small rolled towel under the wrist, and the K-wire is directed 45 degrees dorsal and 45 degrees ulnarwards, keeping the wrist in extension. So when you have mastered the art of K-wires, you can insert a compression screw. This is an example of a fracture of the scaphoid. You can see it's showing a delayed pattern here. And this fracture at the end of 21 days of plaster opened up. So this patient initially with this fracture was not convinced for operative treatment. On 21 day, this fracture is opened up and he was convinced. And this is the result at 6 months with a screw fixation. You can see the A view, prone oblique view, a lateral view, and this is the supine oblique view. What are the steps for percutaneous fixation of the scaphoid using a headless AO screw? This is how you start. Now, AO recommends that you should use a 1 millimeter K-wire mounted on the small guide, or a small, I would say, they have got a K-wire, sleeve. Yes, drill sleeve. I find it personally very difficult to use a 1 millimeter K-wire mounted on a power drill or even on a T-handle and going into the scaphoid. I think the wire bends, does not go properly. You have to have multiple entries and multiple, and it gets quite frustrating. So what I've designed, or what I do is, generally I use a 1.5 millimeter K-wire. I insert it either with a drill or a T-handle, and with these multiple positions, I mark out the entry points and I enter the bone with a 1.5 millimeter wire and continue forwards after proper positioning and reduction of the bone. You can see, you should take multiple views, prone oblique view, supine view. And this, especially this supine oblique view, is very important. If your K-wire goes into this line, slightly very close to the capitate, slightly away, you get the maximum length of the K-wire into the scaphoid if it goes in this way. So a supine oblique view is very important. You put a 1.5 millimeter K-wire in this way, and then on that 1.5 millimeter K-wire, you put in the bigger sleeve of that AO set. It comes with a 1.1 millimeter sleeve and a bigger sleeve for putting the drill. So use that bigger sleeve and put it and slide it right up to the scaphotrapezial joint and touch it up to this place with a 1.5 millimeter K-wire. And then tell everybody in the operation theater to have a statue, don't move, and remove this K-wire from there. And then quickly you insert the 1.1 millimeter K-wire through the same hole in which the 1.5 millimeter K-wire was inserted. And then the job is easier. So now instead of this 1.5 millimeter K-wire, that hole has been replaced with a 1.1 millimeter K-wire. This method succeeds 99% of the times. Occasionally, if somebody has moved or somebody has done some overzealous movement, then you have to go all over again, because it's very difficult to relocate that hole again. So be very, I think you should master this art also of replacing this 1.5 millimeter K-wire with this 1.1 millimeter K-wire. And then you can proceed with the screw fixation as given in the AO manual. So you can see that this is the measure guide, and then screws, the AO screw which is selected for insert or fixing the scaphoid it should be always 3 to 4 millimeters short of the actual measured length. That is very important for achieving compression, because once you get the experience, you realize that if the screw head end goes right up to here, then it can over distract. So your screw should be slightly short of the actual length of the bone that is seen on the C-arm. So this is the procedure which is completed, and you remove the screwdriver, then you remove this 1.1 millimeter guide wire, and that is the final seating of the screw. And that is the same patient, X-ray on the day 1, day 21, and this is 6 months post-op. So the only place, I think the only instance where I use a screw in the antegrade fashion or through the wrist is in these cases of trans-scaphoid perilunar dislocations. I'll just show you one example. Otherwise, it is being covered by Dr. Jindal. So this is a case where there's a late presentation of a trans-scaphoid perilunar dislocation. And in this case, I first use an external distractor. In this case, in this picture, in this X-ray, what I'd like to point out is I use a mini AO clamps, because I found that the round SQLab clamps, they start bending or they start opening up with this, with the type of distraction force that is required. So these mini AO clamps give a very good hold, and I use 2.5 millimeter K wires, 2.5 millimeter shank screws. They are good enough. There is no need to use 3.5 millimeter shank screws to achieve a distraction across the wrist. And then once you get the distraction, once you get all the capsular structures loose, you open the wrist dorsally. And when you open it dorsally, then inserting the screw is very simple. And you can identify especially you should identify the extensor pollicis longus tendon, retract it on the lateral side, and then put the screws and then fix the intercarpal bones and stabilize them in this manner. That is the fracture of the scaphoid, which is healed. The intercarpal wires have been removed. So this is an example which I'm showing you, which highlights the use of K-wires. This is a very interesting case. This was a case of a delayed union following a delayed presentation. This patient presented in October 2005. This is a 28-year-old male, absolutely fit. This was a fracture seen on the X-ray. This patient, after giving the cast, he removed it on his own and then presented 7 months later with this non-union. I would say this is a non-union because you can see a sclerotic bone border, but he refused open reduction and bone grafting, similar to the example which Abhijeet was mentioning. In spite of counseling and all that, he said, I am not interested in any sort of surgery or definitely open reduction, open surgery. So at least we counseled him and agreed to him to undergo K-wire fixation. So this was the K-wires, which are two 1.5 millimeter K-wires were inserted after 7 months after presentation, with the fracture clearly demonstrating a non-union pattern. But K-wires were inserted and plaster was applied. And this fracture is healed in 3 months. So at 10 months, the fracture is completely healed after immobilization with a closed fixation and for 3 months. And this was the X-ray taken after 15 months. And this is the X-ray after 23 months. And this is, now the fracture is completely healed. You can see, unfortunately, this patient was sent his X-ray on WhatsApp and could not make out. And this is the function of the patient after 36 months. So this example proves that or tells us that immobilization of the scaphoid or intercarpal movements, if you immobile or restrict them, the fractures can still unite, as shown in this example. And many more cases have united just by K-wires. The advantage of K-wires is they are easy to insert. The technique is lesser demanding, and learning curve is not so steep, probably, as a screw. Of course, there are problems with K-wires. If you keep them too long, either on the volar side or dorsal side, you can have severe problems, adventitious bursitis, infection, and you can still, this patient had an extensor tendon rupture because the K-wire migrated too much outside. So these are the problems with K-wires. You have to take care, or you have to be technically precise when you insert the K-wires. The advantage of K-wires, you can easily remove them. It is a OPD procedure. Screws obviously don't require removal if they are inserted properly. Otherwise, the removal of the screws can be quite a tiresome job. So I'll quickly now go to my cases of scaphoid non-union. Again, this sentence is very important. They are hard to mobilize, since every motion of the wrist and forearm and hand causes movement of the fracture and pressure on the fracture line. So that's why you get non-unions. Now, this was an interesting table I copied from a journal. So you can see that many cases of scaphoid non-unions were treated in a cast and followed up adequately. They were followed up inadequately. They were associated with this dislocation, and most of the cases have occurred in this paper where ones were not treated at the initial injury and presented with persisting symptoms following re-injury. So that is a very common presentation with a non-union. So in my experience, the causes of scaphoid non-union are neglect or unrecognized injury, or movements or even if you give a plaster cast, the fracture keeps on moving, and that causes the fracture to stop uniting. Or rare cases, or sometimes when implants are not inserted properly, like in this example. So in spite of putting or inserting a screw, the gap remained persistent, and the patient presented with a non-union in spite of a screw. So this is my case of a scaphoid waist non-union. So this I like to operate all these cases of a non-union through the volar approach, irrespective of the level. If only the scaphoid is having a non-union, irrespective of level, I operate it through the volar approach using this modified Matti-Russi technique. I don't use a iliac crest graft. I have not used a volar, I would say vascularized bone graft, and I use only proximal ulna graft, which gives you a pure cortical graft in only one case, and that was the case of a redo surgery. So in most of my cases, or in all my cases, I use a corticocancellous graft. You get a very good quantity of graft from the distal radius, provided your window is quite big. So you make a big window, and you can get a very good quantity of corticocancellous graft from the distal radius, and that is how you go about it. And people who don't have a sharp osteotome, that it is recommended to have a sharp small osteotome. Make the transverse cut first, and then make the longitudinal cuts. If you don't have a sharp small osteotome, you should make multiple holes with a 1 millimeter drill bit across the line of your window, and then complete it with the osteotome and make the window. So this is the fracture which is exposed from the volar aspect. The ends are cleared off and curated. Now this window has been made. That graft you can see has been taken, and then this is the graft. This is the cortical graft which I am about to insert into the scaphoid. You require traction, manual traction on the thumb when the fracture gaps open up, and you require an extension force, and you can insert this graft. Obviously, you have to trim this graft slightly, make it pointed on both ends, and just fit it. You get a snap fit of this graft, cortical graft in the scaphoid. That's the graft which is seen. That's the graft which is seen between the two ends of the scaphoid. And then you can insert the wires, 1 or 2, according to your need and choice. You can insert the K-wires. And then after that, remember one thing, before you insert the cortical graft, put in or insert cancellous graft on the dorsal of the aspect of the scaphoid, because after that, after you insert a cortical graft, you're never going to see that site again. So insert the cancellous graft first, Then you insert this cortical graft, and then you insert the K wires, and then put the remaining cancellous graft on top of this bone on the volar aspect, and then close the wound. That is the case where multiple wires were inserted and the fracture united. So the same policy I adopt for proximal non-unions also. That's the fracture of the proximal third of the scaphoid with a huge cyst seen. This patient presented 11 months post-injury. This was treated with a bone grafting and 2 K wires. This is the X-ray with the K wires removed. You can see the fracture is completely united. You can see the tracks of the K wires. You can see the supine oblique view. This is the PA view. And that is the function at 1 year, I think. And this is the patient who came, the same patient who came to me after 10 years for a metacarpal base fracture. At that time, I have taken this X-ray, and this you can see that the fracture is doing very well here. So non-union of the distal third, this was a huge gap in the which is sclerotic borders. This patient presented after 4 years of the injury. You can see a huge corticocancellous graft is going to be required. So that is the window which I made in the bone, and the corticocancellous graft was harvested. You can see the cortical graft here, and subsequently all the cancellous bone also is incorporating at this 6 weeks post-op. The advantage or my logic or my philosophy is that for the non-unions, you require more of bone graft and less of screws. Because what happens is that screw takes up a lot of space in the scaphoid, which I think could be used usefully if you put a cortical graft in the scaphoid. So that is the reason why I don't use a screw. I have no personal enmity, but I think the more bone graft is more important for union than a screw. And secondly, the tricortical graft that is inserted goes into the fracture side, fracture gap only. It does not go into the proximal and distal end of the scaphoid. So this, I think, which is very important for achieving union. So this fracture subsequently healed. This is the X-ray taken 8 months post-op. And you can see that the donor side, after taking a huge graft, also is completely healed. And that is the function of this patient. Is a manual laborer who has healed. And this is the function of that patient 8 months post-op. So this case is very special for me. I'll show you why. This was a waist non-union. This was a 6-month-old injury. Again, a corticocancellous graft. A single K wire was inserted. More and more cases of non-union now in the past 5 years. I'm using only a single K wire. And that is the fracture which is completely healed. This is the X-ray which is showing complete union again. The reason why this is a special case because I am relying solely on the K wire in this patient to heal this fracture, which is the only useful hand for him because he has a above elbow amputation on the other side. So this case, very interesting. The same case with the diagram or the picture which I shown previously is a case of a non-union of the scaphoid following screw insertion. This patient presented 2 years post-operatively. Now here the screw was coming out here already. It's a very loose screw. The gap is very clear. So in this case, I removed the screw. There is such a huge gap. So I have to take a huge or a large diameter or large cortical graft in this case. So I've taken you can see a wide cortical graft from the distal radius. I shaped it like a acute screw and hammered this graft from the distal end here into the same track of the screw after curating the edges of the screw track. This is the graft, cortical and cancellous. And you can see that only this cortical graft was used as a fixation, but the gap was so big that I found that the graft is giving me good stability. This X-ray is taken after 4 months of the fracture for surgery. And this X-ray is taken 12 months after surgery, showing complete union. And that is the clinical picture showing good function at 1 year following surgery. I thank you all for your attention And thank you for giving me this opportunity.
Thank you very much, Patankar sir. That was excellent. Simplicity of using the K-wire, the rationale of using K-wire was very well brought out. Any questions from the faculty members?
I must admire Patankar sir you, because your methods are very simple and cost effective. That is most important. And it can be done by average orthopedic surgeon. And I have seen number of times now I listen to it since last 15 years. Your methods are very simple and cost effective. That is the beauty of your presentation. And thank you very much for enlightening us with your knowledge.
Thank you, sir.
Chandak sir, next lecture.
Yeah, the next lecture is by Dr. Lad, intricacies
here,
of
I think
intraoperative complications. Yeah,
yes.
so I'll be sharing from my laptop because
No, he's here, I think so.
He's here, but he has preferred to present from my laptop because there is some background noise,
Okay,
etc.
no
So I'll be presenting from my laptop. Just give me a moment before I share the screen. So Parag, I'll be sharing your screen, my screen, and we go ahead.
Yes, sure, sir.
I
Thank you.
thank Maharashtra Orthopaedic Association and all senior faculty for giving me an opportunity to speak in a master class on scaphoid. I have got a very different topic to speak upon. I'm going to deal with, or I'm going to discuss about some of the intricacies of intraoperative difficulties and how do you make our decision while fixing the scaphoid bone. I am Dr. Parag Lad. I'm a hand surgeon from Thane, Mumbai. I'm going to cover about important aspect of exposure. How do you decide about placement of wire? Then should we do the drilling over guide wire? And then about screw length measurements, then placement of screws. And at every step, what we should be careful for, how we should be careful to do this operation, that I'm going to discuss. And we will discuss about some of the decision making. About regarding the exposure, it is a very, very standard approach. Usually this operation is performed under tourniquet control. And for volar approach, it's an extended Henry's approach. And we have to go beyond flexor carpi radialis at insertion site on the radial aspect. And in this approach, we have to be only careful about the radial artery. And we must preserve most prominent and visible branches of radial artery, which are going towards scaphoid region or towards STT joint, because they are responsible for vascularity of the scaphoid. And for dorsal approach, usually we follow this approach around Lister's tubercle. So the only structure that we should be worried about is EPL tendon. Of course, we are going beyond Lister's tubercle, but then this is the structure that we should be worried about. While fixing the scaphoid in the volar approach, we must have the position of the hand as shown in the picture, that wrist in maximum extension and ulnar deviation and full supination. And for dorsal approach, there should be at least 40-degree wrist flexion and ulnar deviation. Sometime it is required, sometime it may not be required. It depends upon the deformity in the scaphoid fracture. And with the why this position is followed is because in this position, the length of the scaphoid is maintained properly. We can see the full length of the scaphoid and it looks in extension if we keep this in position. Now regarding the placement of guide wire, usually volar approach is chosen for west of the scaphoid fracture and dorsal approach is chosen for the proximal pole of the scaphoid. And depending upon the fracture configuration, whether the fracture is transverse in the bone or oblique in the bone, there are three positions from where we can pass our guide wire into the scaphoid bone. So one is from the radial aspect of the scaphoid tubercle. I am going to show that in my pictures. Then one from central aspect of the scaphoid distal pole, and another placement if it is difficult or if it is just distal to the distal waist fracture, then sometime we may have to have a purchase or an entry through the trapezium. It is also accepted. So for the volar approach, these are the three entry points to place the guide wire. So intraoperatively, we must have a screw perpendicular to the fracture line. So it will give maximum compression. And then depending upon whether it is transverse or oblique, we decide these three entry points. Now about the conformation of guide wire, once we put it, you must have standard 4 views whenever you are putting a guide wire. First is wrist posterior anterior view, mainly scaphoid view, that is in ulnar deviation, then lateral view, then supinated oblique view, and pronated oblique view. So sometime once you start putting a guide wire from distal pole, you have to keep confirming that wire placement under Shyam in this view regularly till you cross the fracture site and achieve a purchase in the proximal pole. There is something called, so these are the important views. If we go from left to right, this is how we put the wire, and in this case the wire has been put from the central aspect of the scaphoid distal pole, and this is okay. So this is how we put the wire, and under Shyam control. So once you make an entry into the distal pole, advance the wire, and then again you confirm it into the lateral pole, lateral X-ray, and in a pronated oblique view. And once you do that, then you pass the guide wire. Okay. Then is the drilling required? Nowadays, all screws are self-tapping screws. So drilling is officially not required. The only I prefer to do the drilling over a guide wire. The reason being, it forms a uniform track to pass the screw. The only thing we have to be very careful that we should not perforate the proximal pole. Then you have to do drilling under Shyam control. So what happens if you do the drilling and while removing the drill, sometimes the guide wire may come out. But then because you have formed a bigger track, it is very easy to pass on the wire. And the only problem with the drilling is I am going to show that intricacy or something called complication, that if you change your angle of drilling with the K wire, there is a possibility of breakage of either a drill bit or a guide wire. So you have to be very, very careful, and that becomes a disaster. So this is the case of a proximal pole scaphoid non-union, and actually I wanted to put a screw across the fracture site. It was relatively fresh fracture. In this fracture you could have approached from the dorsal also, but on under Shyam with wrist extension and so ulnar deviation view, the fracture was looking at more or less around the little towards the proximo-distal aspect. So while drilling over the K wire, I broke my drill bit, and that's why I had to abandon that procedure, and I had to fix that wire. I mean, I had to fix the fracture with the K wires. So these are the sequential views, follow-up X-rays. These are the remnants of the drill bits, and believe me, this patient gave me a lot of trouble because he just wanted to get rid of these drill bits. I told him it is impossible to remove these drill bits because they are into the bone, and he kept telling me that these drill bits are irritating my extensor tendon. Some of the drill bits I removed, but it is still, I just took him in confidence and said nothing, it will not trouble you anymore. And to my surprise, the fracture healed beautifully. I removed K wires at 2.5 months, and this was the function at around, this is the 8 months follow. Okay, so the message here I would like to give that if the drilling is not always necessary, if it is only to form one uniform track, but you have to make sure that you do not change any angle while doing the drilling. Next important point is measurement of a screw length. There are three ways we can do that. So first of all, you put the guide wire and confirm the position of the guide wire, and then measure the length under Siam. Okay. So use another guide wire and at the tip of the keep it at the tip of the that scaphoid bone, and you reduce 2 millimeter on either side. So if the length of the guide wire you are getting is around say 28 millimeter, you have to put screw of 26 millimeter size. That is the very standard rule that they follow. There is an article published in Journal of Hand Surgery Asia Pacific, and they have suggested that the length of middle phalanx in a ring finger is usually the length of scaphoid. So you can try that. It is definitely very useful tool, but do not, please go for a confirm with traditional method also. And another thing is you use a proper drill sleeve, the wire sleeve as a measuring device. Okay. Now you have to have proper confirmation of the screw length after you put it, how much you have to bury. If you are going to use any particular implant, usually the screwdriver has some markings, and whenever you are passing the screw and it's a headless compression screw that gets buried into the bone and it has a marking. So if your screw penetrates outside, it is a disaster. Okay. So again, as discussed before, after confirming the guide wire, we take 4 views. This is also after putting the screw, you must take these 4 views: wrist, posterior anterior view, scaphoid view, lateral view, supinated oblique view, pronated oblique view. Longer screw can irritate extensor tendon and it is very painful. Usually it causes tenosynovitis. I have not seen rupture, but I have treated tenosynovitis and rupture has been reported in the article. Let us discuss this case where the patient had a malunion scaphoid fracture. Okay. And this was an old malunion, and we confirmed the malunion first under Siam by, after opening the volar approach, we confirmed the non-union site under Siam, and this was the non-union site. Then we passed the guide wire and we confirm the duck sign in the supinated oblique view. Okay. And then we put the screw. Okay. So this is what is our final Siam picture. So in my view, so this was like a final Siam picture. The screw is appropriately sitting into the scaphoid, but probably I did not check in the pronated oblique view, or somewhere I made some mistake which I did not notice during this operation, and I thought my scaphoid screw is well sitting in place. And when I took, the patient had constant pain on the dorsal aspect of the wrist after slab or support removal, and to my surprise I noticed the scaphoid, in while tightening it, it was too much, buried into the distal pole, and it penetrated the proximal pole and came out. Now this implant removal of this screw is the only treatment, and you do dorsal tenosynovectomy. But remember, you have I have put the screw from distal pole. Now it is impossible to find the hole from where we have made an entry into the scaphoid. It is impossible to find a hole. So in this case, how do you do implant removal of scaphoid fracture? How do you remove the screw of scaphoid fracture? Probably this is the only indication to remove implant is the longer screw or inappropriately placed screws. Sometimes your screw does not have any purchase into the proximal fragment. So this screw I had to, these are the technique. How do we do it? So you open it from the dorsum and you see it was just near the EPL tendon and the screw was penetrating here. So once you expose that, then you pass a guide wire from the dorsal aspect. And now from here, you drill it. Okay. So now I am drilling from here and taking the guide wire on the volar aspect. Okay. So once you do that, guide wire is taken from dorsal to volar aspect, because it is you have to remove the screw from volar because we have put it from the volar aspect. But this is the technique that we have to use to remove the screw. And then, as shown in the left upper picture, the guide wire has been taken out from the volar aspect, and then we have removed the screw from the volar aspect, and patient had, of course, instant relief. The scaphoid was well united. So this is how, these are the technical tips and decision making in considering implant removal of the scaphoid. Another case that I would like to share with you, which is operated by me, and this was the little proximal waist non-union fracture, and this was my entry point into the guide wire was seen in the Shyam that it has purchased into the proximal pole, and somehow I realized that my proximal pole purchase was too small, and probably the entry point was wrong, and the screw was almost out by 3 millimeter, 4 millimeter outside the proximal pole. So this was the final picture. This was the final picture, which I was happy, but only the lateral view. Then I thought I will withdraw the screw little bit, but then I was losing the compression at the bone graft and fracture site. So I left it like that. And to my surprise, it was having a bad outcome. Of course, because patient had no symptom at all, I explained the patient that your screw is not in place, but we should wait for it to heal. And if it causes any problem, then we will reconsider removing the screw. So in spite of, having a proper placement of guide wire, probably the tightening of the screw was too much. So that's why I try to use the implants which are having a proper screwdriver with markings. This is the message here I would like to give. This patient had radiologically bad outcome, but honestly this patient had no pain at all. Okay. Now there is one more case which patient had a proximal pole fracture, and we opened the proximal pole from the volar aspect, and we saw a frank non-union in the proximal pole as shown here. But proximal poles, because I had this bad outcome, where the proximal pole was fractured. So in this case this is the another case where I decided that I confirm this. I curated the fragments very well and then stabilized it with the dorsal aspect. This was just operated few weeks back. Okay. So this is the dorsal entry, and we did a bone grafting and stabilization from the dorsal approach. So the take home message here in intricacies and decision making of scaphoid fracture fixation is be very careful in the approach. If there is a waist fracture, try to approach from the volar side. If there is a proximal pole fracture, non-union or acute fracture, fix it from the dorsal side. Placement of the guide wire, you have to be very accurate. The guide wire can be placed from the radial aspect of distal pole, central aspect of distal pole, or through the trapezium, but you have to confirm the position of the guide wire in all 4 different views in X-ray. Then may have accurate measurement of the screw length, because if you bury the screw too much inside, from distal pole it will look very good, but unknowingly 2 or 3 millimeter protrusion on the dorsal aspect can give significant extensor tenosynovitis. So you have to be very careful in that. And placement of the screw also you need to confirm, as we have confirmed about the guide wire. I thank you for your patient hearing.
Thank you.
Parag, wonderful presentation. Actually,
Thank you,
as
sir.
usual,
Thank you.
in spite of your some tragedy in your house, you have presented very nicely. Thank you very much.
That
Chandak
was
sir, any
wonderful.
question
Yeah.
you want to ask?
That was wonderful, Parag. You brought out the intricacies and you brought out the case of a drill bit also. That was wonderful. That would remind us of what precautions to take. Any questions?
Thank you so
from the-
much.
Yeah. So any questions from the faculty members to Parag? And after this, we'll be having lecture from Dr. Pankaj Jindal, sir.
One question, sir.
Yeah, please
Yes,
go
sir.
ahead.
Yes.
Yeah, if the screw is more prominent on the distal part, if the screw is prominent from the entry point, a bit distal, on the distal part.
Yes, sir.
You're good. Yeah. What's it?
So usually it does not cause any problem because the articular surface of trapezium is little on the dorsal side on the distal part. So even if, but try to make it less prominent, or it should not be prominent. But even if it is prominent, you palpate yourself from outside skin. If you feel the screw head, that means it is going to trouble the flexor carpi radialis insertion. Then you definitely have to bury it. But otherwise, usually that is, not accepted. But if you have no choice about it, then you can let it be there.
So thank you, Parag. That was wonderful.
Thank you, sir.
After this, we'll be having lecture from Dr. Pankaj Jindal, sir. Yeah.
Next presentation is by Dr. Jain.
Dr. Jain is taking up later on.
Taori,
Can you,
Samrat?
can you please take
We'll
up your...
Jindal,
Oh,
sir. We'll take.
Okay,
Yeah.
sorry. So I'm sorry.
Pankaj,
Yes,
be
sir.
ready. Be
Please share,
ready.
please share your screen. Yes, we can see the screen now.
Can you see my slide?
Yeah, we can see your screen.
Okay. MOA, thank you very much for giving me this opportunity to be with stalwarts. I don't think I'm a stalwart or a veteran, but I'll share anyway the SCAPHOID non-union with you.
Make it full screen, sir.
Yes, sir. Okay. Is it full screen now?
No, not yet. I think you can do it from the bottom.
So full screen here.
So not in our screen.
Sir, right side bottom, sir.
Right side bottom, you can go onto that cup.
फूल जैसा दिखता है वो.
मेरे स्क्रीन पे फुल स्क्रीन दिख रहा है मुझे यहाँ पे.
Sir, please continue, sir.
Okay, yeah. Okay, so we'll talk about SCAPHOID non-union advanced collapse. It follows a predictable and set pattern of damage progression. In the beginning, the problem is localized to the distal pole of the SCAPHOID and the styloid process of the radius. As the disease progresses, the non-union involves the mid-carpal joint, where the affection is of the proximal pole of the SCAPHOID and the radial head of the capitate. Further, if the disease goes on, in the third
Sir, excuse me,
stage,
sir. Jindal, sir, it's not the slide is not going ahead.
okay.
So it seems you are playing a recorded version. You are doing live.
No, I'm going live.
Live, no? So I think just go back to again. You can stop share and share again. That will make it simple. You can stop share and then share again.
Okay. Stop share.
Yeah, and share
Share
again. I
screen
think
again.
that, yeah, share screen again. I think that would solve the problem. Yeah, perfect.
It's okay, sir.
Absolutely fine.
Okay.
Absolutely.
Now, so initially the problem is in the distal pole and the radial styloid process. If the disease goes on, it involves the proximal pole of the SCAPHOID. Adjacent affection is of the capitate. And if the disease goes on in the third stage, all the three bones of the proximal row in touch with the capitate gets involved. But the most interesting thing is when the disease is progressing, the radiolunate space is protected. The radiolunate space is protected. The proximal pole of the SCAPHOID and the lunate articulating the radius, this joint is spared. And what is the applied importance? The applied importance is whatever the cartilage is protected, that has to be utilized, whether that be the capitate or the radiolunate or radioscaphoid joint, so that you have a motion saving here. Now, it does not happen over just a year. It takes at least 4 years For this non-unit progress to stage 1, it takes about 9 years to progress to stage 2. It takes almost 15 years to involve the distal end of the proximal carpal row here. A clinical example here. This degeneration involving the distal pole of the scaphoid and the radial styloid process. But the important thing is the proximal scaphoid and the radius is protected. It is spared. Another example here, there's involvement of the radial styloid process and the distal end of the distal pole of the scaphoid, or it is involvement of the proximal pole of the scaphoid and the capitate here. Further, the important thing is, though the involvement is of the scaphoid and the capitate, but the proximal pole of the scaphoid and the radius is saved. Radius and lunate is saved. The applied importance is, if you can have this joint, it can be utilized to have a motion sparing joint movement here. Another example here, the distal end of the styloid process and the distal pole of the scaphoid is affected. Proximal pole of the scaphoid and capitate is affected, but the radius articulating with the lunate, radius articulating with the proximal pole of the scaphoid are still spared. Now, what is the effect of a scaphoid fracture on adjacent carpal bones? What happens in the non-uni here? The scaphoid being a flex bone, the distal pole starts to flex. The proximal pole attached to the scaphoid takes the lunate with it under the effect of the triquetrum, and therefore the lunate goes into a dorsal angulation, what is called as a dorsal intercalated segment instability, or the DC deformity here. Now, what are the effects of non-union? With non-union, the probability of the wrist becoming painful is extremely high. There will be limited range of motion, and there will be weakness, reduced grip strength here. So what are the treatments here? Treatment, as I said earlier, depending on where the cartilage is available. If the cartilage between the radius and the lunate is good, like in stage 1, practically all the cartilage is spared. And therefore, what you need to do is take out the styloid process here, take out this bony bump here, and achieve a union here of the non-union of the scaphoid, and you are okay. But if the patient is presented much later, with the scaphoid, the proximal pole of the scaphoid has started to affect the capitate here, then probably, depending on the extent of this cartilage affection of the capitate, the only joint that is available is between the radius, lunate, and the scaphoid. If the patient is presented still much later, where the whole of the cartilage, the capitate is gone, probably this is the only joint which is available. That is the one between the radius, lunate, radius, and proximal scaphoid here. And therefore, what we need to do is identify where the cartilage is available here. So let's take the first example, the stage 1, where the affection is the radial styloid process and the distal pole of the scaphoid here. Here, most of the cartilage is available, and therefore the aim is to reconstruct everything. Reconstruct by excising this bone here. So we have this here. Radial styloid process has an osteophyte here. Excise this together with about 5 to 7 millimeters of the styloid process of the radius here. Excise this bump here. Achieve a bone union between the non-union here. And what you do, excise the radial styloid process, take out bone graft here, graft it here, and put in a screw or a K-wire here. This is a slightly oblique X-ray, and therefore the screw appears to be outside here, but it's well inside here, and achieve a union here. Bottom line that is important is do an styloidectomy and a bumpectomy here, so that the bony outgrowths are excised here. What about the stage 2 and 3? Stage 2 is where the involvement is of the proximal pole articulating with the capitate head here, or stage 3 is where all the 3 proximal carpal bones are articulating the radius, has caused significant damage to the cartilage of the capitate head here. And therefore the treatment is again to identify the cartilage bearing surfaces which are on adjacent sides here. There are 2 options that are available. One option is, if the capitate head is perfectly good, you excise the proximal carpal row, or you excise the scaphoid and fuse the capitate, lunate, triquetrum, and hamate here. The first is the proximal carpal row. Proximal row carpectomy here. It's technically easy. It's easy to mobilize it 1 month down the line, and there's no lack of non-union. You do not get a non-union, which you are likely to get in cases of four-corner fusion, to which I'll come in a little while here. Whereas in mid-carpal fusion, four-corner fusion here, where you fuse the corner ulnar side four carpal bone, you excise the scaphoid, fuse the capitate to lunate to tricutum to hamate here. What it does, it relieves the pain, it restores the wrist stability, it gives you a good carpal height here, and there's relatively better grip strength, and you get a reasonably good range of motion in these patients here. There was a comparison between proximal row carpectomy versus four-corner fusion here. It was found that proximal row carpectomy, yes, the immobilization is shorter, but it's relatively, the word is relatively weaker grip strength. And therefore, in heavy manual worker, four-corner fusion is relatively better and gives you a better grip strength as well. Do we have some other options when you have a stage 2 and 3 of snack wrist? Option that has been given is you fix the scaphoid here, non-union, and do a wedge osteotomy here. You remove about 3 millimeters of the wedge here. So the radius obliquity is reduced here, and still this goes to give a painless, good range of motion here. So in stage 1, where the cartilage is good, you reconstruct. In stage 2 and 3, where the cartilage of the capitate may not be good, either do a proximal row carpectomy or do a four-corner fusion here. There was a review of literature, a systematic review of existing evidence. It says currently there is no consensus on the treatment of non-union, but the trend is towards combining bone grafting with a internal fixation. Vascularized bone grafting and non-vascularized bone graft gives equally good results here. Source of bone graft, whether you use distal radius or iliac crest, is equally good. Interestingly, the study does not have an olecranon as a source of bone graft here. And the fourth thing is, screw gives about 88% union. KFY has an edge and gives about 91% union here. And further it says immobilization is more in cases of K-wire versus the screws here. Is that the end of the treatment, or do we have some other treatment options? Yes, some other treatment options are available, and this is called a Malarish procedure here, where in stage 1, where there's a osteophyte from the radial styloid process and a bump from the distal pole of the scaphoid here, you excise the distal pole of the scaphoid here, and again this gives a reasonably good range of motion, which is painless with a reasonably good grip strength here. So this was my patient here. There is osteophyte on the radial styloid process involving the distal part of the scaphoid, non-union here, and I excise the distal part of the scaphoid here, and that bone from the styloid process of the radius was excised as well, and went on to reasonably good range of motion here. Four-corner fusion, various options are available here. You fuse the capitate, lunate, tricutum, and hamate here, and utilize the good cartilage of the lunate, which is articulating with the good cartilage of the radius, to have a good range of motion after excising the scaphoid here. There are various options to fuse it. There are various plates which are available here. This was earlier, this is the latest, and you can use these spider plates here. As against, this is the German article which took a big chunk of bone. After decoating the 4 bones here, put it on top and put 4 screws here, and went on to good union. And what has been achieved here? What happened?
You have exited your presentation.
I didn't know.
Yeah, you have exited.
Okay. Anyway,
problem.
so this was
We can reshare. No problem.
Okay.
Yeah.
So
yeah, we are able to see. Just maximize it. We are able to see the slide. No problem.
okay. Anyway,
We are able to see fairly.
so
Don't worry.
then you, as against plating, you can use K wires. There are other methods of fusion between the 4 corner bones here. But these are various options. The bottom line is, whatever you do, what is important is the cartilage, the lunate, and the cartilage, the radius are good enough. So that's as against proximal row carpectomy. Four corner fusion is another option when you are having a patient who is stage 2 or 3. That is, the involvement is of the cartilage of the head of the capitate here. This is another option of fusion of the proximal pole of the scaphoid with lunate and capitate here. What is my choice? My choice is proximal row carpectomy, cast it for 6 weeks, and patients do extremely well. You excise the scaphoid, you excise the lunate, you excise the triquetrum, and patient does extremely well here. They are painless. There is no possibility of non-union, which is a possibility in four corner fusion. So this was one example of a patient who had a scaphoid non-union here, and it is involving the head of the capitate here, and therefore I opted for a proximal row carpectomy because I think part of the cartilage of the head of the capitate is still intact here, and therefore I opted for a proximal row carpectomy because cartilage of most of the head of the capitate is still intact. And if you see here, over a period of 3 months, his grip strength is gradually increasing and has a reasonably good range of motion here. This was yet another patient who underwent a proximal row carpectomy. So I feel it's an extremely good option. I have not done any four corner fusion because consistently proximal row carpectomy has given a good result in my patients here. What are the other options? Wrist denervations, implant, pancarpal fusions. If all the cartilage is gone, probably you just fuse the wrist to get away from the pain here. So in summary, consider restoration if the cartilage is good. Identify good cartilage matching surfaces. If the cartilage is bad, then see whether the cartilage of capitate is good. If capitate is also not working, then do a four corner fusion and utilize the matching surface of the lunate and the radius, and go ahead and fuse the four corner fusion. Go ahead with four corner fusion. So those are the common procedures that are in vogue for snack wrist here. I thank you very much for patient listening here. Thank you very much.
Thank you, Pankaj, for bringing out a very important topic and actually a difficult topic. And you made it really, we were made to understand the topic nicely. So giving a good advice of preserving whatever we can preserve, otherwise do a proximal row carpectomy. Thank you so much.
Thank you.
Any questions from Gadegone sir or other faculty members?
Sir Pankaj, suppose if you are fusing it, is there any much more strain on the single joint which is left, and that also get degenerated in during the course of time?
7 years, 10 years down the line, you may see degenerative changes, but surprisingly, the changes are more radiological rather than pain. So they may not have pain down the line. You may see on the X-ray because the radius of curvature of the capitate and the radius of curvature of the radius, they are different. So yes, on the X-rays you might see, but in reality you don't see. I recall last sentence. I recall one patient who was a manual worker working somewhere in Middle East, and I have been following him up for last almost a decade now, and heavy manual worker, and with PRC is doing extremely well.
Okay, so this is one surgery which is technically in scientific mind appears difficult to give result, but it gives good result. So somehow the patients are happy after proximal row carpectomy. And I think Abhijeet wants to comment something.
I just had a question for sir. Sir, does the morphology of the capitate, like sometimes we have a pointed capitate when there is a type 2 lunate, does that have any bearing on performing a proximal row carpectomy, sir?
Okay, once we have decided we are going to do a carpectomy, so whether the radius of curvature of capitate is less or more, it does not have a bearing on either the outcome, long-term outcome. Yeah, so I'll still go ahead if the cartilage is good.
Thank you. Thank you.
Probably the important thing is once you are excising the carpal row, see to it all the ligaments on the volar aspect are not damaged, so that the bed of the new joint is good enough to have a good support.
So
Don't damage the volar structures.
Pankaj, if I can ask you, what are few important silent features? How do you proceed with proximal root carpectomy once you have selected the patient?
Okay, I over the period have started using more of a transverse incision.
Okay.
First on the radial side, you dissect out go between the second and the third compartment, or second or fourth compartment, because the third compartment is extremely small. You now open up the third compartment, isolate your extensor pollicis longus tendon, separate it.
Okay.
Do a dorsal arthrotomy, flex the wrist.
Okay.
Once you flex the wrist, probably the first structure you are going to see is the head of the capitate.
Right.
Just be most respectful to this capitate head, because that's cartilage is extremely important, is going to be deciding the fate of your success or failure of your results. And now, proximal and radial to the head of the capitate, as you flex the wrist, you will see the scaphoid here. Once you see the scaphoid, take good quality
scissors.
Take good quality short 5 millimeter osteotomes or 2 millimeter osteotomes, and with a small hammer, piecemeal take out your scaphoid. From the scaphoid, you go more proximally with a flex wrist. You will see the lunate. Having excised scaphoid and lunate from the radial side, then change your approach again and go on the ulnar side of the fourth compartment. Pull your extensor digitorum communis tendons to the radial side and excise the triquetrum on the ulnar side now.
Okay.
Once you have done it, wash your joint, remove all the bone debris here, and I think you should be okay with this thing.
Yeah, perfect. Thank you so much. Samrat, you wanted to ask some question? Yeah, fine. So with this, I think we would like to listen to Samrat now. Our own Samrat can go ahead, please. Share your screen, Samrat.
Sir, one more case by Dr. Jindal. Are we taking it?
You just present your
Samrat, please you.
Yeah,
Not
and then
Samrat.
again Jindal sir would come.
Yes.
Okay, sir.
So you're presenting complex scaphoid injuries.
Yes,
So
sir.
please share your screen. Okay.
So is the screen visible
Yeah,
nicely?
yeah.
Yes, sir. So thank you for this opportunity, sir. And I take up this complex scaphoid injuries because there are two things in this. One is fracture scaphoid with a trans-scaphoid perilunate type of injury. Another is distal radius fractures with scaphoid fractures as another condition. And we are going to discuss few cases on distal radius fractures with scaphoid fracture. And please tell me when to stop. So this is a young male, MBBS student. He had a fracture, road traffic accident, distal radius fracture, scaphoid fracture, and first metacarpal fracture. Problem is that he had injury in the morning. He got his X-ray done. Then the medical officer got his CT done. And I saw him, unfortunately, after about 10 hours. For 10 hours, he was not immobilized. The hand was in dependent position. When I reached, he was having severe swelling in the forearm. The fingers were flexed, the MCP joint was slightly extended. He was into compartment sort of situation. But since I was going to take up next day morning, we just immobilized him and took up for surgery next day. These are his CT scan. We understand that radial styloid is making the whole, is a game changer as far as the distal radius is concerned. He also has got scaphoid fracture, and the base of the metacarpal is quite comminuted. These are the CT scan pictures. Left to right are the, distal to proximal. So this is distal and this is proximal. We first fix the scaphoid because there are literature which says that first fix the scaphoid and then move on. So first K wiring and then fixation of scaphoid. Then we fixed the radius, and then at that point of time we stopped. One was the reason was swelling. Another was that we were exhausted and the tourniquet time was done. So I think it's okay if we stop at about 3 hours and say, okay, now we will do it next day. So next day we went again and we did this fixation as far as possible, as much as we could do. And this was open. This was opened fixation of the base of the first metacarpal. And not satisfied, we did an external fixator here. And so the radius, as much as we could do. So there was a comminuted fracture on the lunate aspect, on the dorsal as well as on the volar aspect. So the dorsally we fixed this plate, but on the there is still a fragment which I could not finish, could not fix, and I just put a K wire here as much as for the fixation. And to highlight here is that we had two slabs, plaster slabs, one for the on the both the aspects, volar and dorsal aspect. This is 6 months post injury. K wires were removed. The fixator was removed after 3.5 weeks, and the K wires were removed after about 8 weeks. And the fracture seems to be healed well. And this seems that the base is good, but still there is some irregularity here. And after listening to the lectures since morning, I feel all my scaphoid screws need a revision now. He has got a good ROM, but I have a botheration that the ROM is more on the mid-carpal joint here. Sorry. Yeah. So this is yesterday's video, 8-month post surgery.
Yeah, nice moments.
So what I want to highlight is this fellow was a medical student. From day one, he was instructed exercises, elevation. We can also see that we have got I had opened on the volar aspect also because he had median nerve symptoms on day one in the presentation. So I had released the carpal tunnel also. And he has got some restriction of the carpo-metacarpal joint. And Kapanji score wise, he is not able to completely oppose. He is able to oppose till here, not here. And he is doing well. So early rehab and very sincere rehab this fellow has got. And now after 8 months of his surgery, his pronation supination is complete.
Yes,
So
documented.
he has started doing his gym. So this is the second case where we had a fracture of the scaphoid and the distal radius, again quite comminuted, closed, and there was ulnar styloid fracture. The point to highlight here is that the instrumentation was not very ready for a scaphoid fracture fixation here. Maybe because it was in hurry. We did this case, we did the first case with Nakul Chandak. This was Dr. Faisal sir's case, and he fixed the distal radius, and I was called up for putting a scaphoid. The screws were just not good. So we had put this K wires, and the K wires were removed at 3 months. Patient is doing quite well. This is 4 months post surgery, and it seems that it is doing well. Third case is quite complicated distal radius fracture with distal radius with the scaphoid, and this is recently done. It was a hell of a job, and we are still in a situation to understand how it's going to work. This is the case done yesterday, run over by car. He has got a dislocation of the carpo-metacarpal joint, and the X-ray did not show fracture scaphoid, but we actually required it, so we did it. So he has got a fracture scaphoid, he has got distal radius, just 2 minutes, sir. Distal radius, and also some comminuted fracture of the capitate and the hamate, and a small spiral fracture of the proximal phalanx. Again, we first fixed the scaphoid, first fixed the radial styloid. He had a radial styloid fracture, first fixed the radial styloid, then the scaphoid, and then went on to reduce and fix the carpo-metacarpal joint. And finally, we also fixed the this fracture because we wanted to mobilize him. Today his morning was, he started his exercises as well. So want to just highlight that all these injuries require a lot of systematic assessment as well as early mobilization. And this is a case discussion for our seniors to highlight what they feel about approach to these cases.
Thank you, Samrat. Nice collection of cases. And you brought out the complexities of injuries to the distal end radius along with scaphoid. Nicely done as well. So any comments from the faculty members?
The most important thing, if you have multiple fractures, you fix everything so that you don't immobilize them. Because if you immobilize, the amount of stiffness that you'll get will be phenomenal. And to get out of that stiffness will be a nightmare.
Right.
And therefore, fix everything so that you have minimum external immobilization and early range of motion.
Absolutely. And I think in these cases where distal end radius and scaphoid is there, fixation with K-wire is more preferable, Dr. Hemant, sir?
Samrat, unshare your screen.
So my question to Dr. Hemant Patankar, sir, when these patients of distal end radius and scaphoid are coexisting, is it more preferable to fix with a K-wire for a scaphoid fracture?
No, it does not really, that is
Not the selection criteria.
The point of consideration. If the implants are available and if the fracture fragment is fracture is in the waist or something, I think we should go with the screw, because as Dr. Jindal has said, we must mobilize everything fast, because K-wire may definitely, though the fracture unites, the mobilization is later.
Okay.
So it is always better to have a screw.
Screw for the scaphoid and
For the scaphoid.
distal end radius
Yes.
plate.
With other associated injuries, one should go in for the screw, but a proper screw.
Okay, perfect. Yeah, Sauji sir, you go ahead, please ask.
And a question for Dr. Taori. The first case, he has used plate and external fixator. Now, why used slab, plaster slab? Samrat?
Yes, sir. So the plaster slab was one for the soft tissue healing. Second, it was for the scaphoid, sir. Scaphoid is unforgiving. Even if you put, I believe that even if you put screw and everything, then still it requires immobilization at least for 6 weeks. External fixator was for the first metacarpal, sir, because even if you put in this comminuted first metacarpal, it just collapses. So it requires at least external fixator for 3 weeks.
Okay. Thank you, Samrat. Good cases. Now we go ahead with Dr. Jindal's next presentation. Can you share your screen and go ahead with your presentation, sir?
Conduct, sir, will finish at 1 p.m.
So this is very interesting topic, scaphoid, sir. And I presume, and there are a lot of good feedbacks from young registrars and lecturers that it helps them plan their scaphoid surgery better. I think we are not constrained. We go ahead and have both the lectures. So please go ahead.
So can you see my slide?
Yeah. Please go ahead.
Okay, so non-union after scaphoid fracture here. The two things that we'll talk about is why and what next. So we have this patient with a fracture of the scaphoid here, and he's 18 years.
Screen is not moving. Screen is not moving.
So again, as you said,
and you can make it full screen, sir, again.
You can keep your present. Yeah.
Make it full screen. Slide show from the beginning.
Yeah. He is there. He's clicking.
Can you see that?
Yeah. No, still we are seeing the not the full screen.
Okay. Anyway, can you see the slide?
Yeah, we can.
Go ahead with the.
So fine. So we have this patient who is 18 years old, male, and 2 years old, non-union. Now what we see here, there is a halo around the screw here.
Just click on slide number 3 so that we can see that. Click on slide number 3 because we are seeing the first slide only.
Now, second.
No, we are not able to see.
It is not moving.
What you can do is keep your presentation open in the full slide mode, and then click share and then do it. I think that would help you.
Now?
Yeah, perfect.
Okay, fine.
Yeah, perfect. Yeah.
Oh, so we'll talk about why what happens if there's a non-union after an internal fixation here. So this 18-year-old male had a non-union which is of 2 years duration here. Now what we see, there's a halo around the screw. So my guess is probably I think the tap was oversized. And that's the only reason why the screw has become loose, because the indication for screw fixation is that you do an early mobilization. So probably it was not the early mobilization which caused this problem. It was, my guess is it's an oversized tap which caused the problem here. And further, there's a distraction here. So what did I do here? The important thing was, again, removal was not very easy here. So I made the trough here, remove this screw here. Now two things here. Important thing in any non-union is debride the non-union, put a lot of bone graft and internal fixation here. So first thing is debridement. You curate out all the bone along the passage of the screw and from the non-union site here, then pack it with a lot of bone graft. Here, probably I thought this bone available from the distal radius will be inadequate. So I took iliac bone graft here. But if this was not the case, my usual preference is to take this bone graft from the distal radius here. Once the screw was removed, once the passage was debrided, once the non-union was debrided, I packed it with bone graft and put 3K wires here. And this is how I converted a non-union into a fixation here. And this was after 19 months here. This is the ulnar deviation view here. And this is where I had begun. Remove the screw, fix it with K wires, and this is a union. I called him the other day here, 2 days back. It's 3.5 years. He said, I have no pain. I can do gym. I have full range of motion and I'm happy. Here's a range of motion. I know this is a funny view, but that's a WhatsApp image that he has sent to me here. And this is the final after union here. On the patient here, fracture the scaphoid, fixed with 3 K wires here. I think the purchase that we have on the distal pole is inadequate. And further, we have a gap and they were rounding here, indicating there's a non-union here. The next thing is these wires are outside here. I think the fixation should be from farther distal here so that we have more purchase here. This would give adequate purchase here. But this had to be revised here. The next problem, the bent K wires gets entangled in the overlying dressing and it exerts a tug and causes undue movement at the fracture site. And therefore, my preference, if I'm using a K wire, is to bury the K wires and not leave them outside. If at all, rarely, if I would put them outside, I'll rather not have them bent because I feel that's an unnecessary lever on the dressing material here. And therefore, this needs to be fixed again. Third patient here. This patient had a screw which was not only long, but there was distraction at the fracture side here. Again, the management was taking out this screw, debriding the fracture site here, putting K wires here, 3 of them here, and pack it, and this went on to union here. The next patient here. Here, there is no purchase on the proximal fragment here. There's a gap. And if you see, this screw is almost parallel to the distal radius, which means this screw it should be along the red line here. It should be somewhere here. And therefore, this is outside this radius, outside the scaphoid here. And therefore, again, this has to be changed here. What I did, I removed this screw here, put a lot of bone graft here, immobilized with K wires here. These are slightly going inside the radius here, but anyway, this is inside the cast. And in due time, these K wires were removed here. So again, as I said, this should be just inside the lunate, it should be just inside the scaphoid and should not go into the radiocarpal joint here. But I bone grafted it here. This is the source of bone graft here and immobilized with K wires here and went on to union here. So this is where we had begun. We removed the screw, debrided it, put bone graft and immobilized with K wires here. It went on to good union here. There was an article here in one of the journals here. All these cases that I have shared here, I have used a non-vascularized bone graft. And this fact has been endorsed in this article. You can get away with all these patients with a non-vascularized bone graft here. Non-union may not justify increased time and technical demands of vascularized bone graft. Not that I don't do vascularized bone graft, I do vascularized bone graft, but in these cases, vascularized bone graft is an overkill and non-vascularized bone graft is good enough here. And therefore, traditional repair should remain the first line of treatment in these patients who require a revision surgery here. Magnification helps in a big way. A tourniquet helps in a big way here. And these are the two main things. Of course, other things are go with it. Fine instrumentation goes without saying here. So in summary, remove loose implants, debride the passage, debride non-union, put lot of bone grafts here, fix it with K-wires or screws, immobilize adequately and uninterrupted continuous, changing the dressing again and again every week for financial reason probably harms the safe environment of healing, and therefore don't change the dressing. Once you put in the plaster, it comes out only once you are ready for removing it, which is about 6 weeks if the K-wires are being used. Non-vascularized bone grafts, conventional bone grafts are good enough, don't require fancy vascularized bone graft. I thank you very much for patient listening. Thank you once again.
Thank you, Pankaj, for bringing out nice points and making us remember that cut, bury, and bend your KYS. Do not keep them poking out of the skin. Thank you very much for that tip. Thanks a lot. And quickly, you can move on to your last lecture. I will take it up. CRPS is one of the very common problems after hand injury cases.
Okay,
And
one question while I load my presentation. I will take time.
No problem. Take your own time. Yeah. Any comments from Abhijeet, if you would like to make, or Dr. Patankar? Go ahead. Samrat, go ahead.
Samrat, please.
Sir, have you ever considered, or would you consider putting a K-wire from scaphoid to capitate to stabilize it?
From capitate to
scaphocapitate K-wire for about 3 weeks or 6 weeks in situations where there's a huge bone graft, like a gap, and you have used it.
No.
Or for the stabilization.
No.
So Samrat, you are asking about a large chunk of K-wire to be stabilized to both proximal and distal pole of scaphoid. So why not a K-wire would hold it there?
No.
I meant to say that putting a wire from a distal pole of the scaphoid to the capitate.
Yeah, I got your point.
Yes,
so what I'm telling you is there is a large bone graft, there is a proximal pole of scaphoid, there is a distal pole of scaphoid. So if you put two K-wires, they would hold nicely this graft also. So why to adjoining capitate? Any reason?
It has been described for additional stability.
Additional stability is the reason for that.
Scaphocapitate wire is described for about 3 weeks for additional stability.
Okay.
It's a described method.
Yeah.
I do it occasionally if I feel that K-wire, single K-wire is going to cause too much or not going to bear the load. I sometimes put a scaphocapitate wire. Not very routine.
This is in addition to the K-wires which we are going for fixation.
Yes. Okay. Now I have started using more of bone graft and less of K-wires. So I use only one K-wire and one probably scaphocapitate wire, but that's very rare. Another thing which I would like to comment on the Dr. Jindal's case is that I have stopped using a drill for using the screws. I use the K-wire because the I think insertion of 1.5 millimeter K-wire which I used initially and then replaced it with 1 millimeter K-wire. So already I've got a hole of 1.5 millimeter. If there is a need or if I feel that the bone is very tough, I make a drill hole only on the distal fragment where the head of the screw is going to enter. I don't use a drill on the whole shaft of the scaphoid. It gives me a very good purchase because our Indian bones, there is no guarantee of the amount of calcium there.
And this,
I'm scared.
Yeah, and you must be preventing the overheating with K-wire with a lot of copious saline irrigation as well.
Yes. Yeah. No, I use the load speed drill. Many times I use the K-wire with the hand. So there is no question of heat generation.
Okay. And
can I say something very quickly?
Yeah, this is basically to prevent drill breakage and to have a better purchase.
No. It is not
Better-
for drill breakage. It
better
is to
purchase.
prevent that loosening of that screw which Dr. Jindal described.
Okay, perfect.
In his
Abhijeet,
case.
yes, you wanted to make comments,
Just very
please.
quickly, so the
Yeah.
scaphocapitate K wire is basically more appropriate in scaphoidal ligament repairs or injuries because the scaphoid has a very high bending potential. It flexes. So to prevent that flexion and to maintain it in extension and to offload the repair.
Okay.
Sometimes in proximal pole fractures, the same thing happens with the distal part of the scaphoid. It tends to flex, and to stabilize that, we often have to then put in a scaphocapitate K wire. It's just to prevent the bending moment of the
Just a minute.
scaphoid.
Got the point. Absolutely fantastic. Thank you so much.
Thank you, sir.
So, Pankaj, you can go ahead, please.
Can you see my slide
Yeah, we can see.
Oh.
your slide.
now? Yes. Okay. So we'll talk about post-operative care, and the fourth thing that we'll talk about is the cast, elevation, sling, and range of motion.
Yeah.
Cast.
You will have to click on second slide. So this is non-moving slide syndrome we are facing.
Again, stop slide,
Yes.
share the screen, presentation, share.
Yes, I think you are there.
Okay. So
Okay.
we will talk about the cast.
Yeah, please go ahead. We are seeing that.
The cast.
Yes.
I use a plaster spica. It is applied on the table and it remains there till it is required, which is almost 6 weeks here if I'm using a K wire. It includes the thumb. The interphalangeal joint of the thumb is free. The fingers are free. Now, this kind of cast is an absolute no-no. This defies logic. If anybody applies this cast, he should be failed. I'm sorry. But
Okay.
this is an absolute no-no here. The plaster cast immobilizes the IP joint. It keeps the IP joint free. The MP joints of the other fingers are free. It has been recommended by one of the people on the scaphoid fractures that current recommendation is you keep the thumb free. The problem with our population is they are going to ride their motorcycle, they are going to hoist their motorcycle on the stand, and they are going to cause distraction at the fracture site. And therefore, I personally feel this is an unsafe thing for our kind of population who will put us into trouble. And therefore, my recommendation is to use a cast which immobilizes the thumb here. You should see to it your cast is trimmed adequately so that the MP joints of the fingers are free here. Elevation, this is a different patient. This is, of course, an injury here. Elevation is an absolute yes, all the patients here. Elevation, elevation, and elevation here. A plaster with the wrist flex going across the IP joint is an absolute no-no. MP joints of the other digit has to be free here. This is a non-functional position of the hand here. This is going to be not only painful, but this will unnecessarily be labeled into something else, to which we'll talk in a little while here. Do we change the plaster? Unless the drain has been used, the POP is not removed. After the cast, we talk about the elevation. The elevation is above the heart level all the time, 24 hours a day, 7 days a week, except for maybe few seconds down the line, where it's for comfort level, but otherwise the hand remains elevated above the heart level. Shoulder elevation 5 times every week to prevent shoulder stiffness, elbow stiffness here. What am I showing here? The hand is at the level of your belt here. The veins are visible here. If you take it to your level of your umbilicus, the veins are still visible here. If you take it higher up to your costal cartilage level, the veins are still visible here. They come to your chest pocket, the veins are still visible here. You come to your almost shoulder level, the veins are still somewhat visible. It is only when the hand goes above the heart level, above the shoulder level, the veins start to disappear. And therefore, once you start elevating, that is the only situation where your transudate and exudate will not accumulate and generate the glue and lead to stiffness here. And therefore, hand has to be elevated all the time and has not to be in the dependent position here. Sling. They restrict shoulder and elbow range of motion. They force the hand to remain dependent. They make the hand stiff, and they're the best advertising for your hospital only. And therefore, Slings do not help the patient, they help you. And therefore, as far as I'm concerned, I do not use the slings. They are harmful. They cause the hand to remain dependent. They make the shoulder and elbow stiff. Therefore, no slings, absolutely. Range of motion. The shoulder bracing, contract the interscapular muscle, the levator scapulae, the rhomboids 5 times every half an hour. Full range of motion of the fingers, wriggling the fingers 100 times a day, it is not worth it. But making a full finger flexion 10 times is far more effective than 100 times of wriggling. And therefore, full range of motion is absolutely essential from day the anesthesia wears off here. What about the use of hand? The fingertip use for laptop is good enough, but driving two-wheeler or four-wheeler is absolutely not permitted, because people start then misusing the hand and start doing everything. And therefore, absolutely no here. Because the only thing is they start misusing the hand. And the problem is the result. The result goes bad, the surgeon is bad. And therefore, no. What about plaster duration? The plaster remains on for 6 weeks, especially if the K wires are used. If you have used a screw, you can remove it in few days time, because the few days are important, as Samrat said, about soft tissue healing, the skin to heal. If the proximal fold fracture is there and I've used K wires, I'll immobilize for about 8 weeks here. And even the suture removals I'll do after 6 weeks after the plaster removal is done. I am not opening it for suture removal after 2 weeks if the K wires have been put in there. After the plaster comes out, the active range of motion and strengthening begins. I like to paper crumpling, handkerchief crumpling. This is a good exercise for mobilizing the fingers. Dhadu, broom is a very good exercise. I ask the patient to hold a small broom here, because that serves two purposes. One, it gives you strength, because they don't want the patient to lose the grip on the broom. And second thing, it gives flexibility to your wrist here after the fracture has clinically united. Clinically united means the tenderness in the anatomical snub box has disappeared here. Wringing clothes is another good exercise for strengthening. Hold it for one hand and start turning the towel so that you start wringing the clothes here, and that again gives you more strengthening to your fingers here. And this will be the beginning of resumption of activities of these patients here. What about K-wire removal? I'll remove the plaster after 6 to 8 weeks here, but wire continues for 4 months, at the end of which the K-wires are removed under local anesthesia here. And as I said, they are buried, they are not outside the skin here. Coming to complex regional pain syndrome here, there has to be an initial injury here. The pain is out of proportion to the injury here. Presentation, there is warmth, there is redness, there is shiny skin, and is swollen here. And you do not see any other reason for such an appearance there. There are two types of CRPs here. One which is associated with nerve injury, and type 2 which is not associated with nerve injury here. And the commonest reason for CRPs that I have seen is when the external fixator is used and overstretching of the joint is seen, that causes overstretching of the nerves here. I do not see this condition in my patients here. And it is extremely important to differentiate CRPS from a stiff hand here. An extremely important article came, which I request all of you to see, is in the Journal of Hand Surgery, European 2013 here. It was an article which was published from the editor here, and editor was Francisco Pinal. I remember the name because he did fellowship with me and Kleinert. And he said, I have a dream. Reflex sympathetic dystrophy type 1 does not exist. And what he says further, our work as scientists is to challenge unproven knowledge. CRPS1 offers an unparalleled dustbin where all difficult problems and patients are dumped. The editor further says, I'm amazed how the medical community is so stringent in diagnosing most conditions, but accepts the most mysterious CRPS1. The editor further says, there is no etiology for CRPS1. There's no clear-cut clinical signs and symptoms for CRPS1. There's no diagnostic test for CRPS1, and there's no effective treatment for it. And still you accept a condition called CRPS1. We all agree there's an overreaction, hyper response to a painful stimulus. But What if the stimulus is present and we are not able to diagnose this? I'll skip a few slides here. Are we overlooking something? I'll skip a few slides here, but probably this is important. Are we missing a subclinical nerve entrapment? Are we missing a subclinical carpal tunnel syndrome? And therefore, if we are able to identify one of the nerve component here, it will not be a CRPS1, it will become CRPS2. It becomes CRPS2, you treat the nerve entrapment and you will be having a reasonably happy patient here. Dysvascular, as Dr. Abhijeet was mentioning, smoker are bad patients. They have a poor vascular level, a poor oxygenation level here, and therefore disease encourage these patients to desist from smoking, because they have to encourage their oxygen level to have a good healing and have a better smooth recovery here. They may have further nerve entrapment in these patients, which may be subclinical to start with. And therefore, if you see a patient differentiate, you have to read this here. I saw a girl who was trying to write a thesis on CRPS here. And she came to me that if I can give her a lot of patients of CRPS. On hearing from me that I have seen only 2 in my lifetime, she started crying. Yes, she started crying. After consoling and promising that I'll look out for genuine CRPS, I took her contact number. The matter was forgotten until about 6 months later. I chanced to contact her again, and calling her up again, she said she has completed her thesis with 20 patients. On asking some scientific questions, she politely said, "Sir, the thesis has been accepted by her professor." To her, whether they were CRPS or not was immaterial. Whether they were stiff hand or dependent edema was inconsequential. Her thesis has been accepted by her professor, and she was relieved. And therefore, CRPS is often mistaken for a stiff hand, and we mix up and we end up in problems here. This is the response I got from Pinal. We had some correspondence. He says CRPS is rest in peace for proper diagnosis. It's a shelter for bad doctors here. He further said in the editorial, which I am again requesting, please read this article. It's extremely thought-provoking. It is hiding bad doctoring. It's hiding our bad results here. We must look out for why this is stiffness, and probably like this patient, this was labeled as a stiff hand here. This was labeled as a this was labeled as a CRPS. This was labeled as a CRPS, where it is a non-functional position. Just take the wrist back into an extended position and everything will fall in place here. Is there a relation here? If you elevate your hand above the heart level, the blood which is trickling, the hematoma which is trickling, it will come into the forearm and not accumulate in the carpal tunnel, and they will not end up into a subclinical median of compression. Therefore, a plea for elevation of these conditions above the heart level. And therefore, in summary, elevate above the heart level, do not use slings, early full range of motion, immobilize if you are using a K-wire for 6 to 8 weeks here. CRPS, I think it's overdiagnosed. Stiffness is not CRPS. Bad posture is not CRPS. Dependent swollen hand is not CRPS. You have to keep your hand elevated, immobilize with the wrist extended, unless, of course, you are doing your flexor tendon surgery or the volar surgeries here. Keep your wrist extended, flex your MP joints here, and we are unlikely to see any problem in most of these situations. If at all you do see one of them, then look for carpal tunnel syndrome, look for median nerve. Do not depend on nerve conduction studies, because often the reports are subjective and may not tally with your findings. Look for Tinel sign, look for Fallon test, carry out Fallon test, radial nerve, look for your tenderness in the mobile VAD here and see if this is tender, or if it is ulnar nerve, do a passive elbow flexion test, do a Tinel sign here and rule out any subclinical nerve entrapment. Otherwise, you can have a very stiff hand, which you might end up with a CRPS. I thank you once again, MOA. Thank you, Dr. Chandak. Thank you, Samrat, for giving me this opportunity. Thank you once again.
Thank you, Pankaj. You brought out very nice points in managing edema, stiffness, and venous return. Quick question to faculty members. Patankar sir, no sling. Your take on that?
I agree.
Totally agree.
I don't use these ready-made slings anyway.
So when they are in the working mode, so how do you ask them to keep their hand? onto the chest, onto the opposite shoulder?
Yes, I asked the patient to immobilize the hand on the opposite shoulder.
Abhijeet, your take on sling, use of sling, because that is the most commonly used practice. So any take on that?
It is
Yes, sir,
mostly
absolutely. Just like sir said, I always tell them to keep it at heart level or at the opposite shoulder level, and also mobilize the elbow and the shoulder, and then not to kind of have any constricting kind of bands around the hand also. So always mobilize all the joints that are not immobilized, keep the elevation,
Okay.
and that's usually the and while they're sleeping, they can sleep on the operated side so that that hand remains elevated, or they can keep a pillow on their stomach and keep the hand on the pillow. So that also.
Okay. Gadegone sir, your tips for reducing edema and stiffness?
It is always actually what standard teaching elevation and exercises. But how far it is practical to say the patient or to instruct the patient that you follow the instruction and that should be all the way your hand is above the heart, because the mechanism of hand positioning in natural is the downward, and to keep him against gravity upward. So it is not practically possible. So majority of the patients, they don't follow it. We have to instruct them physically as well as mentally, and then they will follow. Otherwise, majority of the time, we say that you elevate, they elevate, but majority of the time, they don't follow. That is my observation.
Okay. Thank you very much. Thanks for all the faculty members for bringing their best in giving these presentations, and the topic was really interesting. And I hope this must have given a lot of inputs. I have myself noted a lot of inputs from the presentation. That was wonderful. Any last minute comment from Pankaj on scaphoid non-union? Any two important tips to delegates?
Okay. Over the period of time, I've almost literally stopped using vascularized bone grafts, because now at least 3 articles which said MRI saying avascular necrosis is a misleading diagnosis. Dead bone, there was another article which said dead bone added to dead bone does not give live bone. That is not true. Even if the MRI says it's a dead bone, it's a avascular bone, you curate it, bone graft it conventionally and fix it, and it works.
Okay.
It was an article by David Green. It said it does not work. No, this is again not true. So over a period of time, in last 2 or 3 years, I have not done a vascularized bone graft. I again have started using more and more of K-wires, and I'm reasonably happy with not using screws quite often.
Thank you so much. Abhijeet, your 2 main points and bone graft in this scaphoid fracture management.
I think diagnosis and not missing the fracture is very important. So very proper and careful history taking, imaging, having a very high index of suspicion, taking into account the mode of injury, and maybe lean towards over treating than under treating. Explaining to the patient all the outcomes, spending time to help them understand their options and outcomes is very important, and proper rehab and trying to prevent complications by sticking to proper technique, and physiotherapy and rehab is extremely important.
Thank you so much.
The last question I want to ask.
Yeah, please go ahead.
All faculties, after immobilization for 6 weeks, in any form, whether it is a non-union or whether it is an acute fracture, there is a surrounding periarticular wrist osteopenia, and that also gives us some trouble. Is there any how to avoid this, and what is your tip?
Sir.
Yeah.
Hello.
Yeah, please go ahead.
Yeah, I respectfully disagree with you, sir. Nothing happens. I immobilize the patients for about 3 months. Provided your hand is kept mobile all the time and elevated, and the fingers are mobile all the time, we have hardly seen any periarticular osteopenia. Only when the patient has an implant in the joint and gets pain, then you get these sort of complaints.
So your observation is this is as against the lower limb, say for example, calcaneus fracture in cast, and then they develop profound osteopenia. It does not happen in hand, is what
Yeah, I have not seen. I would ask Pankaj to.
Yeah, Hemant, you're right. The finger movements is extremely important. He keeps moving the finger here and elevated, and we don't see this osteopenia which Vasudeo is mentioning.
So take home message that if you do elevation and exercises, as you see in other fracture periarticular osteopenia because of immobilization, does not happen in the injuries around the wrist joint.
Finger movements are continued, and we presume their vitamin D and sunlight exposure are adequately maintained.
Yeah.
Thank you very much, everyone. And with this, closing comments from Samrat, and then we close the webinar.
Samrat,
Yes, sir.
you do closing ceremony as well as the thank you ceremony. Both the
Thank you, sir.
Thank you, ceremony. That was interesting.
Okay, from the bottom of my heart, I really tell one thing, that we are proud that we have got very good hand surgeons in India who are teaching us, and what experience they have shared today is more than what is printed. So we thank all the faculties. We started with Dr. Wahegaonkar sir, then Dr. Patankar sir, and then Dr. Jindal sir led us to very nice intricacies. And Dr. Parag actually shared his own cases and what we need to learn from his experiences is to avoid that. We also thank Maharashtra Orthopaedic Association, Dr. Gadegone sir, and Dr. Savji sir was there since the beginning, Dr. Chandak sir and Dr. Sangeet Gawhale sir for this opportunity, for this meeting. The closing comment is just to not to miss it. That's it.
Thank you very much.
Thank you very much.
Thank you, sir.
We'll have another webinar from you.
Yeah,
And
thank you very much.
Patankar
Savji sir, Savji sir, any tips for further improvement? You just let us know. As an executive of MOA, any guidelines you would like to give? Please go ahead. I think Savji sir is dealing. So thank you, everyone. Let's close this.
Have a nice
Thank you very much.
Thank you very much. Thank you so much.
Nicely.
Thank you so much.
Thank you. Thanks, Samrat. Bye.
Bye.
Bye, sir.
We can close the proceedings. OrthoTV, we can close this webinar.